So, I welcome you all to the first World Regional Anesthesia Day, which is being held at Sancheti Hospital in Pune. And the theme is training and safety of regional anesthesia. So, this will be followed by a message from the ESRA President, Eleni Moka, which is followed by a couple of topics. Dr. Kala is going to speak on RA practice in resource limited setups and how to ensure safety. This will be followed by how to keep our tiny tots and surgeons happy by Dr. Anju Gupta from Delhi. Mitigating nerve injury after blocks. This will be delivered by Dr. Anjolie Chabra again from Delhi. Prevention of conversion of acute to chronic post-surgical pain. This topic will be handled by Dr. Pratibha Jain Shah from Raipur. How to improve my blocks. This is by Dr. Chaitanya again from Bangalore. And I'll be speaking at the last role of cadavers in regional anesthesia training and research.
Greetings to everyone on the occasion of World Regional Anesthesia Day. Thank you, Dr. Sandeep, Diwan, Dr. Anju Gupta, and the organizing team for having me here. I'm Dr. Kala Eswaran, a freelance anesthesiologist from Dombivli, Maharashtra, India. We'll be speaking about regional anesthesia in limited resource setups or low resource setups. No disclosures. This is the photo and video consent form, which we take for recording purposes, which also helps us in medical legal purposes. Advantages of regional anesthesia. Regional anesthesia is very much prevalent because of its superior analgesia to opioids, giving significant pain relief, having fewer life-threatening complications intraoperatively, and severe respiratory complications postoperatively, decreasing airway manipulations. It was a very favorite during the COVID era, and regional anesthesia took on a great momentum there. It has decreased response to surgery, thereby keeping the parameters much stable and hence decreasing the ICU stay. There is decreased blood loss, especially during orthopedic surgeries. All this causes early ambulation, early mobilization, decreasing the incidence of DVT. And regional anesthesia has a resource sparing compared to the general anesthesia. All the above factors reduces the cost of regional anesthesia as compared to general anesthesia. This is the low resource setup. This is a small nursing home setups. Okay, no additional help is available and ultrasonography may not be available everywhere. Challenges of limited resource setups. Unavailability of equipments of that is peripheral nerve stimulator, the ultrasonography is not available everywhere. The drugs, what you prefer, local anesthesia drugs and the intralipid in terms of when you have lignocaine, local anesthesia, systemic toxicity is not easily available. Unavailability of trained personnel and expert help who are on the same page as you will not be available in limited resource setups. Unavailability of good conducive infrastructure. You may not get a room to give the block even in high volume centers. The sterile trolley, the sterile tray, and there is nobody to help you around. Unavailability of good monitors, intraoperative, while giving block, or even post-operative care is very much lacking. And in short, there is lack of standard universal regional anesthesia protocols. This was a study which retrospectively analyzed data collected from free Android app called as Anesthesiologist from the December 2015 to April 2020. And it showed that the practitioners in low and middle income countries accessed the app more frequently than in high income countries. And these mainly focused on surgical blocks rather than the post-operative pain block, which was more preferred in the high-income zones. Uses of regional anesthesia in low-resource setups, mainly 80% cases are done for surgical blocks that is used as sole anesthesia agent, and among that, almost 90% is central neuraxial block, okay, and some peripheral nerve blocks, and sometimes even local infiltration of anesthesia is used with mild sedation. Peripheral nerve blocks in conjunction with central neuraxial blockade, and general anesthesia in conjunction with central neuraxial blockade or peripheral nerve block reduces the requirement of inhalationals, opioids, and post-operative ICU requirement. Okay. Spinal anesthesia is the basic mode of anesthesia in low resource setups requiring minimal, just the spinal needle, LFL syringe, and a sponge holder and gauze. So all for spinal anesthesia is preferred for almost all the cesarean sections and any surgery below umbilical. And lately, during COVID, thoracic segmental spinal gained favoritism for surgeries above umbilicus also. Epidural anesthesia as compared to spinal anesthesia is preferred less because it needs time mainly and expertise. It increases the cost of the set, and it has to be maintained. Sterility has to be maintained. Staff awareness and training is needed, especially if you are keeping the catheter and post-operatively it is used for post-op analgesia, and you have to be careful, label it well, and train the staff. But it gives better patient parameters, can be used for longer duration of surgeries than the spinal, and can be used for post-operative pain relief also. Practitioners from the low and middle income countries access the regional anesthesia app more than the high income countries. This was from the study. And what nerve blocks they had access to were ankle blocks, axillary blocks, interscalene brachial plexus, supraclavicular brachial plexus, wrist blocks, digital blocks, even local infiltration field blocks or hernia blocks, mainly blocks which are used as sole regional anesthesia. Okay, that is the surgical blocks, and or femoral blocks for lower limb surgeries after spinal is given, and fascia iliac compartment blocks were for on arrival blocks and for post-operative pain relief. Regional anesthesia specific techniques. Now, 80 to 90% of practitioners in the low resource setups use central neuraxial blockade, and in that, the 90% thing is almost always spinal, and 10 to 20% goes for epidural because it's safe, effective, and has a definite yes or no. The central neuraxial blockade is almost always predictable action, and it's easy and effective to learn to. Okay. Peripheral nerve blocks, if you stick to simple landmarks, minimal equipment need blocks, then it can be easily used in low resource setups like axillary or femoral block. And slowly you can combine the regional anesthesia with sedation or regional anesthesia with light GA. You can optimize the resource available, especially in low resource setups. Most important barrier for regional anesthesia is you yourself, the training and the motivation, because it needs, you need to spend, and there are expenses towards learning, attending workshops, conferences, and to upgrade yourself, and expenses towards equipments and drugs. You have to initially spend some amount, and you have to give time and dedication to master a regional anesthesia technique. In that process, you may have to lose family time, you may have to lose your cases, no? And you have to answer questions from the patients and relatives and surgeons. Maintaining the data and logbook goes a long way to towards safe regional anesthesia, and even medical, legal, and litigation purposes, this is very useful. So Documentation also takes your time. And all this starts from the pre-anesthesia checkup room itself, where you can meet the patient. As soon as you see, your mind will start thinking which block I can give, and you will start preparing the patient, talk to the patient about the regional anesthesia technique, and explain to the patient to get his full trust and cooperation. And when the patient gives you full cooperation, the surgeon definitely helps you and gives his full cooperation. And in that, after pre-anesthesia checkup and thinking about the block, you can read, upgrade yourself, talk to your friends, and formulate a well-planned regional anesthesia. And you can prepare and teach the staff also how they can help you and train them accordingly. My journey of regional anesthesia in low resource setups was first getting the epidural sets, then the block needles, then acquiring the PNS machines, convincing the patients and surgeons for regional anesthesia, making drugs available, talking to pharma companies for drugs, the local anesthesia drugs, and the intralipid, and the pharmacy to keep them available, creating awareness in the local area by giving talks and talking to the hospital owners and surgeons, training the staff, taking out time and training the staff for regional anesthesia, making feedback forms and getting feedback from the patient and staff, and finally, publications to confirm all these findings. Okay, epidural. First of all, I had to procure the epidural needles, started labor analgesia in the vicinity, established epidural for surgery and post-operative pain relief. Therefore, you just need an attitude and intention to think with a needle and an LA-filled syringe. Getting the PNS machine, the block needles, and the latest ropivacaine drug. Initially, we were using blocks for as sole regional anesthesia technique in humerus fractures, the interscalene brachial plexus block, the supraclavicular brachial plexus block, the axillary nerve block. The orthopedics were more open to blocks. It reduces the patient's stay, cost, and early discharge. Wrist blocks, the fascia iliaca compartment block. This was one block which really was like magically made the patient pain-free pre-operatively itself and allowed me to give the central neuraxial block easily, and the post-op pain relief was continued. The femoral nerve block and sciatic nerve block and ankle blocks were used for sole anesthesia agent, and from there we upgraded ourselves to use PNS and came to chest wall blocks and abdominal blocks, that is the truncal blocks. Initially, C-arm guided thoracic paravertebral blocks were given, and then we graduated to landmark guided and the PNS peripheral nerve stimulator guided, and then to sonography. Thyroid, many thyroid surgeries were done under superficial cervical plexus block successfully with minimal sedation. Cancer tongue lesions. This was a patient, a 92-year-old mother of a doctor who insisted on regional anesthesia. She was hypertensive, diabetic, and had some age-related ECG changes. We gave glossopharyngeal nerve block, the tonsillar pillar 3 ml, midline of the tongue we infiltrated around 3 ml, and superficial cervical plexus 6 ml of LA, intermediate cervical plexus 5 ml. LA mixture used was 2% adrenaline xylocaine along with 0.75% ropivacaine. Sedation needed was just 1 milligram of midazolam along with 1 gram paracetamol IV. This 88-year-old with severe COPD came for bilateral radical neck dissection. This patient on induction while giving GA had a respiratory arrest and hence was postponed. And then we did this case under plain sole regional anesthesia using bilateral superficial cervical plexus block successfully. You can see the nasal prongs going on. We had maintained all the safety prophylaxis, keeping all the resuscitation drugs ready. Parotidectomy in a patient with cardiac disease. This was successfully performed under sole regional anesthesia, and thyroid surgeries with thyroid cancer with cranial metastasis was done in this patient. This patient had lung metastasis too, so we wanted to avoid GA and post-op ventilatory care. So we did this case total thyroidectomy under bilateral superficial cervical plexus, and cranial metastasis was done under scalp block. Okay. Scalp block was successfully used with minimal sedation for many awake craniotomies where the motor area tumors and where we needed patient cooperation to map the extent of the tumor. Hernia block, this patient was for right inguinal hernia with severe COPD, kyphoscoliosis, and a ejection fraction of 25% was successfully done under hernia blocks. Blocks as adjuncts with general anesthesia and central neuraxial blockade used as rectus sheath block, the TAP block, PECs, the erector spinae for lap procedures, adductor canal and femoral blocks for total knee replacements, rectus sheath block and subcostal TAP blocks for lap cholecystectomies and other lap procedures, 4-quadrant TAP blocks for obesity surgeries, hernias, cesarean sections, hysterectomies. Perianal block was very effective in piles, fissures, and fistulas for post-operative pain. When using blocks in combination with for good patient outcome, commando with PMMC flap in a patient with 20% ejection fraction, thoracic paravertebral block using peripheral nerve stimulator was given, and the mandibular nerve block along with superficial cervical plexus block was given in landmark guided technique, which reduced the GA requirements and intraoperative complications, and post-operative recovery was very good in this patient. Mandibular nerve block in a patient with dental abscess improved the mouth opening because of pain, excellent pain relief, and which allowed us to intubate successfully after giving the block. Perianal blocks, landmark guided blocks, 2-point perianal block was used to give excellent post-op pain relief, which was later on published too. Rescue blocks, as we graduated and got confidence in patients, we could give confidence in regional anesthesia, we could graduate to exclusive rescue blocks like radial nerve, ulnar nerve, median nerve blocks, popliteal sciatic nerve block, and adductor canal block using sonography or PNS, abdominal blocks like TAP blocks and rectus sheath blocks. Now coming to the failure. Failure is mainly due to misjudgment of the nerve distribution. You are not, you have judged wrong and the wrong nerve has been blocked. I have not given adequate soak time, and the patient may have intrinsic problems which resist the action of the local anesthetic agent, and hence you should be prepared with rescue blocks or repeat blocks, and as far as possible use peripheral nerve stimulator or sonography. If not, then do not hesitate to give GA, and therefore you have to be prepared for general anesthesia always, and hence the OT upgradation. You have to keep convincing and keep going after the hospital management and surgeon to upgrade to a good workstation with good resuscitative drugs, and you have to upgrade yourself also for complications and keep available the intralipid for any lignocaine, local anesthesia, systemic toxicity. This is the drug, and keep it in the vicinity. Complications like nerve injury is avoided by using peripheral nerve stimulator and sonography, which helps in monitoring the needle to nerve distance while giving the block. Even blunt tip needles helps in preventing the nerve injury. Okay, and injection pressures while giving the block should be monitored to avoid nerve injury. And finally, keeping the data of what block you have given, how many blocks you are giving in a month, what kind of block, the block characteristics, then the standard monitoring which you are using, which is required, whether the lipid rescue is available or not. Your time in and time out has to be written down, the total blocks which you are giving, and accordingly you can keep things available. So keep your logbook and your documentation always, so that later on you can publish your work also. This was thyroid surgeries under bilateral superficial cervical plexus block, a case series published, and 100 cases of paravertebral block for modified radical mastectomy. This is a case description of a case of CA tongue with neck dissection under regional anesthesia. Then using peripheral nerve stimulator guided thoracic paravertebral block for modified radical mastectomies in high-risk cases, a case series, and novel 2-point perineal block injections for post-operative pain in proctological surgeries. These are my publications, and this is the pocket book which we published in 2019 for regional anesthesia techniques. And you have to keep going, thinking, do the PAC, talk to the patient, and in general, document and learn about your population. Go after the healthcare system, upgrade your healthcare system. You have to be a part of the healthcare system too. And hence you have to train yourself, train your staff, and continuous upgradation to get a proper regional anesthesia success in terms of safety. And this will avoid any type of litigations. You have your documentation to save yourself and save regional anesthesia. Hence, you have the pearls will be give time and your dedication, be perseverance, follow the safety protocols. Nowadays, you have internet, your YouTube, keep reading and keep seeing what others are doing. So follow resuscitation equipments, the supraglottic airway devices, the drugs always ready. Keep training and upgrading yourself. Use logbook and feedback to keep your self-audit. That will help you in improving your regional anesthesia techniques. And continuous learning is the crux for safety. And safety means it will keep you away from all types of problems, litigations, and safe anesthesia practice, a safe patient. Mission Chandrayaan, India, though being low resource setup, we managed Chandrayaan-3 with minimal amount spent. Okay, so if keeping that in mind, take the leap of safe regional anesthesia practice. Thank you.
Good evening, everyone. How to keep our tiny tots and surgeon happy. So today I'll be sharing some tips to successfully practice and safely practice the pediatric regional anesthesia. I have nothing to disclose other than some photographs in the presentation might have been included from the educational sources in internet. I'll be discussing some anatomical and physiological differences in pediatric population, the barriers to use of pediatric regional anesthesia, the safety of regional anesthesia in children, and various blocks which are commonly practiced in this population. This statement from Swafford and Allen can sensitize you to the pathetic state of affairs of pediatric pain management in the past. Pediatric patients seldom need medication for the relief of pain. They tolerate discomfort well. A large observational study in a developed country like France in 2003 showed that only about 34% of neonates were receiving any kind of analgesia following painful procedures. Today, we are in a much fortunate space, we are much aware of the importance of pediatric pain management. There are multiple hemodynamic and systemic effects of untreated pain. Untreated pain in newborn period can lead to formation of abnormal pathways, can lead to impaired social and cognitive skills, and various patterns of self-destructive behavior. So there are certain general principles of management of regional anesthesia before we go on to the specific aspects. We must always acquire dexterity with regional anesthesia in adult patients before we barge on to these techniques in the pediatric population. These are very delicate structures. The pediatric patients, they have a very delicate structures, and we cannot just jump onto the pediatric regional anesthesia without first acquiring that expertise in adults. We should always know the anatomy and sonoanatomy well. And as Gaston Labat had mentioned, that anatomy is the foundation upon which a successful regional anesthesia is based. So we should always be aware of the anatomical and pharmacokinetic differences in this population. And we should be aware of the sonoanatomy of these pediatric patients well. A small attention to detail, like we should avoid neuromuscular blockers if we are planning to perform these blocks using nerve stimulator under regional general anesthesia. These kind of small details, we need to be very careful when we are practicing pediatric regional anesthesia. Then the main thing to remember here is that the age is never a bar to the successful use of regional anesthesia, and these blocks can very safely be practiced even in preterm neonates, and the type of blocks are only limited by the skill and interest of the anesthetist. So there was a notion that double the anesthetic, double the risk. Is it so? This article in pediatric anesthesia, it mentioned that pain control with regional anesthesia decreases the opioid requirement, which in turn improves the recovery and fastens the recovery, decreases the surgical stress response by decreasing the stress hormone release, decreases the surgical blood loss, improves the support care, avoids the general anesthesia in certain high-risk population, decreases the use of inhalational agent. All these in turn will lead to an improved recovery of the patient in post-operatively. Hence, this notion is absolutely a myth. So what are the barriers? Despite the awareness of the benefits of regional anesthesia and the awareness of the adverse systemic effects of untreated pain, there is we all are aware that the pediatric regional anesthesia is very underutilized. What are the barriers? There is a limited knowledge of pediatric drug metabolism and dosing, because most of the time the anesthesia is given by the occasional pediatric anesthetist who might not be aware of the intricacies. There is a diverse range of developmental and physiological changes during childhood. The efficacy of pediatric regional anesthesia is hard to judge because these patients are often under general anesthesia as compared to adults, where we can immediately judge our block efficacy. There is always a need for sedation and general anesthesia during the procedure, and safety is a main concern in the pediatric patients. So using a regional anesthesia, there is always a concern of safety, whether these procedures are safe in pediatric patients. Also, many anesthesiologists have this concern. And also another very important barrier here is the surgeon's perception of pediatric regional anesthesia, which still remains a work in progress. Hence, to make the pediatric regional anesthesia work for us, we always need to take the surgeon on our side, and surgeon should always be our customer if we want to practice regional anesthesia in children. So before we go on to pediatric regional anesthesia, before we start practicing it, we should be aware of certain anatomical and physiological differences in this population. The nerves and the vessel, all the structure, they are very, very small. There is very little adipose tissue and the structures lie close together. Hence, there is a potential risk of injury to nerves and the structures around them. However, the saving grace is that the ultrasound imaging improves the accuracy of needle placement. The endoneurium has a very little connective tissue, and nerves have shorter diameter with incomplete myelin sheath, which leads to early onset of both sensory and motor block, which can result in a prolonged motor block even with dilute concentrations. The dural sac, it ends lower down. Hence, we should be aware of the risk of dural puncture during caudal anesthesia. There is a high cardiac output, which leads to increased systemic absorption, and there is a high proportion of cardiac sodium gated channels in open state. All these in turn lead to increased risk of cardiac toxicity. Then there is a risk of drug accumulation with prolonged infusion of the local anesthetic. So this local anesthetic toxicity in infants is a real concern because infants have an immature hepatic metabolism. There is an increased total body water. Plasma proteins are less, so resulting in more drug in active and free form. And there is a rapid increase in blood levels due to the higher cardiac output. So, however, the saving grace here is that there is a decreased minimal local anesthetic concentration which is required to block the impulse conduction, because nerves have a very thin myelin sheath and nerves have a smaller fiber diameter and a shorter internodal distance. So adequate surgical anesthesia is achieved with even smaller concentration of local anesthetic. The most commonly practiced pediatric regional anesthesia block word over is caudal block, because it is very, very simple and easily adaptable to even ambulatory anesthesia practice. And it needs only a basic equipment, that is even a hypodermic needle and a syringe will suffice to perform this block. And anatomy of sacral hiatus is very easy to identify. So it is an easy block to learn. And also a continuous caudal block is very easy to practice because the high thoracic catheter advancement from caudal insertion site is possible in this population. There were some risks related to caudal block like dural puncture, hematoma, infection, all these things, dural puncture, these things can be overcome, have been largely overcome by the use of this ultrasound block. Use of ultrasound can easily help us identify the dural sac and also identify the needle trajectory. So many of the complications have been can now be avoided. Regarding the epidural block technique, the ligaments, there are some differences that the ligaments are thinner. Hence, it may be difficult to feel the length of loss of resistance technique. Then the midline approach is preferred because lamina are not well developed. Epidural space is very superficial, so preferably we should use shorter 2E needles. The distance being 6 millimeter at birth, which increases to only 10 to 12 at 1 year. There is a simple guideline to determining the epidural depth, that is 1 millimeter per kg of the body weight. Dosing guideline, we can go for 0.1 ml per kg per year per segment in children more than 10 years. And for less than 10 years, we should go for 0.04 ml per kg per segment. Thoracic epidural catheter should always be performed by the practitioners who are very experienced in the pediatric thoracic epidural anesthesia. It is not a very simple and easy technique. It requires a lot of expertise, and it can be very risky if the spinal cord puncture happens under general anesthesia. Then advancement in adult regional anesthesia, pediatric regional anesthesia has in fact been benefited lot more by the advent of ultrasound. The use of ultrasound has led to the possibility of various blocks which were earlier thought to be difficult or were not commonly used. Now, if you name any body part or any kind of surgical procedure, there is some block which can be performed, and all the major surgical procedures can be covered by peripheral regional anesthesia. Hence, there is a boom in peripheral regional anesthesia in pediatric population. We have a lot of safety information nowadays. There is advancement in pharmacology. We have safer drugs like ropivacaine. There is improvement in regional anesthesia equipment, and of course, the ultrasound. Then, as you can see in this graph, there is a steady increase in the regional anesthesia, peripheral regional blocks as compared to the neuraxial blocks in the recent years. Ultrasound, how it helps is by decreasing the local anesthetic dosing. As we are all are aware that there is a limit to local anesthetic which we can use in this population. We have to be very precise. Then we can precisely locate the structure and deposit the drug around it, so which decreases the chances of vascular puncture and improves the safety and decreases the local anesthetic toxicity, and also increases the local anesthetic block efficacy. A large regional anesthesia registry, that is PRAN, the Pediatric Regional Anesthesia Network, which analyzed more than 1 lakh blocks, it found no permanent neurological deficit in in its analysis of more than 1 lakh blocks. So it is a very, very reassuring finding. However, there is a very interesting finding that the complications were 7 times more in the awake group as compared to those under general anesthesia. Similarly, the study by French Language Society of Anesthesia found that there was no increased risk under general anesthesia as compared to awake state, but the complications were much more in infants less than 6 months and much more with central neuraxial block. Hence, there is an increasing trend towards peripheral nerve blocks. So this debate of awake versus asleep has been put to rest. Now there is an absolute consensus that peripheral and neuraxial blocks in children can be performed anesthetized, and anesthetized block do not seem to increase any kind of injury. Regarding the blocks, we should always go for safer local anesthetic like ropivacaine and levobupivacaine instead of the more toxic agents like bupivacaine. We should always limit to the maximum allowable doses. We should know and we should calculate it beforehand. Whenever we are planning any kind of regional block, we should calculate the maximum dose and we should limit the dose. And also we should limit the maximum infusion doses which are permissible, and we should be aware that in infants younger than 6 months, we should go for only half the doses as compared to older children. And beyond 36 hours, we should further half the dose which is allowed. And in fact, we should preferably not practice the continuous infusions more than 48 hours. This article by blocks, for most of the blocks, we can go for a dose of 0.25 to 0.75 milligram per kg. So how to prevent systemic toxicity, which is one major concern of all pediatric anesthetists while practicing pediatric regional anesthesia, especially for younger children. We should always go for a lesser toxic dose. Now, drug like levobupivacaine, ropivacaine, which are now freely available in most of the theaters, we should never exceed the maximum available dose, and we should in fact half the dose which is maximum permissible in the neonatal population. We should always inject in small aliquots and always aspirate repeatedly before injecting the full dose. Then ultrasound should always be used. We should all be, pediatric anesthetists should all now be familiar with the use of ultrasound, as it allows precise deposition of the drug and it allows the visualization of the injection, thereby preventing an intravascular injection. We should aware of the limit of the maximum infusions which are permissible, and we should limit the infusions to a maximum of 48 hours in neonates. Always an epinephrine containing test dose should be utilized, though the effect may be limited by the type of general anesthesia, but it should always be practiced. And children should always be monitored whenever they are being given any kind of regional anesthesia, especially the continuous nerve blocks. These kind of charts are now freely available, which are available even with our AORA website, and all the major societies, they have published these kind of charts. And these charts also mention the pediatric maximum dose, pediatric dose of lipid emulsion, which can be used, and they are easily available and handy. We can print and paste them in our operation theater walls. And whenever any kind of regional anesthesia is practiced anywhere, lipid emulsion, it is needless to say that it should be available. So pediatric blocks, regional anesthesia, as I have already mentioned, that it is a very it wears off very fast, even faster than the adult blocks. So what is the solution to that? We can go for adjuvants like dexamethasone, dexmedetomidine, clonidine. So many adjuvants are nowadays available. Whichever you are familiar, that you can go for those adjuvants. However, preferably you should avoid these adjuvants in neonates and young infants. My favorite is clonidine. We have published this study of use of clonidine as adjuvant to supraclavicular brachial plexus block, and it has been found to increase the block duration by at least 3 to 4 hours. Then this is another study of use of clonidine as adjuvant to spinal anesthesia for infraumbilical surgeries in children, where it was found to increase the duration by 1 to 1.5 hours. So what happens when the surgeon decides to use multiple incisions? So we should always discuss with the surgeon the possible incision site. Then we should choose our blocks which will cover those sites, and then we should customize every the blocks as per every individual case. How we can do that? We should calculate the total permissible dose for that child, divide that into individual blocks being planned. We should go for most distal blocks which will require the minimum amount of local anesthetic. We should go for safer local anesthetic. We should dilute the permissible dose to the required volume, because volume is ultimately very important. We should space out the blocks. If we think that the block dose may be exceeded, we can give one block in the beginning and one block in the end. And for uncertain incision where the surgeon may decide the surgical procedure during the course of the surgery, we can end additional blocks at the end of the surgery. Another important aspect of practicing regional anesthesia is that we should always watch our needle. We should watch the needle end. Always our needle end should be visible at all times to avoid any vascular puncture, to avoid injury to critical structures like pleura. We should always also keep a safe distance from the nerve, because the neural injury, they may be very subclinical, very subdued, and they may not manifest. The children may not complain. So it is always better to bargain on the safer side and keep a safe distance from the needle tip from the nerve. Always try to use triple monitoring of ultrasound, injection pressure, and the nerve stimulator. However, always remember that the technical skill and vigilance of the anesthetist is probably the most important aspect. Appropriate equipment decreases the chances of injury. Use appropriate probes, smaller probes like hockey stick probe, smaller needles, and appropriate smaller syringes, and smaller spinal needle. Everything should be used age appropriate, which will improve the chances of success, and also it will increase the safety. Consent and documentation is very, very important. This is one infraclavicular block which led to prolonged Horner, delayed onset of Horner syndrome, and the child is apparently very distressed because this complication was not expected out of a infraclavicular block. And when the child was counseled and the parents were counseled, the child was it resolved on its own, and the child is happy the following day. So we should always try to counsel and document any kind of complication which happens, and we should monitor and regularly audit any kind of complication which occur. So what is the key to planning a successful pediatric regional anesthesia? Communication, communication, and communication. So communicate beforehand with the surgeon regarding what is their plan. The plan may change at the last moment. Communicate with the patients and the parents. Never assume anything. Many patients, many even children, they may be adamant about being awake during the surgery, and you can plan a block which will keep them calm, which will allay their pain, and which can cover the surgical incision, and we can even practice a awake regional anesthesia. So we should always discuss and ask for the preference. They want to be awake, they want to be asleep. So we can always discuss out and plan the things. We should always plan and communicate with our anesthesia team so that they are aware of the plan and we can discuss out the risk and benefit. How to choose the block? We should always consider the anatomical aspects like the site for the surgical incision, what are the possible blocks which can cover, but we should go for the distal most site specific block. We should also consider various medical conditions and anticipated duration of postoperative pain. Make ESP block your friend. This is one favorite block of mine, which covers almost all the surgeries from the neck till your even lower extremity. So this block, erector spinae block, I have practiced it for most of the upper abdominal surgeries, thoracic surgeries, and now even I have started using it for some lower extremity surgery also. And it can also be used for shoulder surgeries as it has been reported. It has a very good safety profile and it has a very simple landmarks which are easily available, easily visible. That is the tip of the transverse process. So the dosing is 0.5 ml per kg per side, and then target vein is immediately deep to the erector spinae muscle. So it covers it is said to cover the ventral and dorsal rami of the spinal nerves. We also use it for the scoliosis surgery and the patients are very, very comfortable for almost 24 hours. And I especially use it for open pyeloplasty, where I have found a pain relief of up to 24 hours. Continuous blocks can very safely be practiced in this pediatric patients also. However, there is always a concern of local anesthetic toxicity and migration of the catheter. So the children need to be monitored well, and it is relatively less practiced in the pediatric population. There are certain papers which are upcoming on this continuous usage of the continuous infusions. Now, another aspect of pediatric regional anesthesia is to avoid general anesthesia in patients where there are complicated cases. Like in a child who had multiple drug allergy, we can avoid regional and general anesthesia by the use of awake regional anesthesia. Then a child who had acute hepatitis, the use of interscalene brachial plexus block is another report in a child with acute URTI. All these cases where general anesthesia was thought to be, the child was thought to be at a higher risk, the general anesthesia could be avoided by the use of regional anesthesia. Like in these cases, which is my experience for awake regional anesthesia, these are the preterm infants who were very high risk, who had bronchopulmonary dysplasia, who had episodes of apnea. They were given awake spinal anesthesia and they did very well. Then this is a child with cretinism who had anticipated difficult airway, who was in a very pathetic condition when he presented to us with rectal prolapse, and it was done under awake low subarachnoid block. Then this child of osteogenesis imperfecta who had a very difficult type 3 osteogenesis imperfecta with multiple systemic effects and multiple fractures all over the body. She was posted for this multiple osteotomies, and it was a prolonged procedure which was performed under continuous spinal anesthesia with only dexmedetomidine sedation. Then another thing is that you should always make technology your friend, because nowadays all the children, they are tech savvy. They are very, very happy to have technology by their side, and you give them technology and make them do anything. We can practice spinal anesthesia, nerve blocks in awake state with mild sedation just by using technology, various kind of technology, distraction techniques, whether it is virtual reality, smartphones, anything can be used. Now we should be aware of the new block, and we should keep ourselves updated by regularly going through the materials, all the new publications, and attending the CMEs. We should always keep ourselves abreast with the latest literature which is available in the like this block, pudendal block. This can be used as an alternative to the conventional caudal block, which is always used for procedures like hypospadias, which are very, very common procedure in the pediatric population. I have been practicing it and I have been doing some projects, and I have found that it provides a very good analgesia. And in fact, there is no opioid requirement at all in the first 24 hours. So it is a boon to us to be aware, to be updated, and to be aware. So another block in the another kid on the block is the sacral ESP, which I have started practicing for multiple surgeries. This is one patient where I used it for unilateral sacral ESP for lower limb surgery in pediatric patient. There was no requirement of opioid in the post-operative 24 hours. Also, in cases where there are sacral anomalies, which are very common in patients, especially those with anorectal and malformation. This is my report on unilateral sacral ESP. And this is one child with coccygeal abnormality, where sacral ESP, we thought that we should avoid the caudal block, and we used sacral ESP, and it provided a very excellent analgesia in first 24 hours. Now, training is another very important aspect, which we should be very train our staff and our juniors in regional anesthesia. There should be a structured program starting from simple blocks like caudal, penile, femoral, axillary, ilioinguinal, rectus sheath. These are very simple, beginner-friendly blocks which can be practiced. And training should include ultrasound guiding, scanning, and needling techniques. So it should begin from phantom training, then proceed to adult volunteer, then older child, and then finally we should go on to the younger children and infants. So now to summarize, we should always be aware of the right patient, right site, right equipment, right block, right drug, and the right dose when we are practicing pediatric regional anesthesia. We should always inject after careful aspiration. Intralipid should be handy always, whenever we are practicing any kind of pediatric regional anesthesia. We should always document and audit our blocks, and we should not take anything for granted. Any kind of complication which happens, we should document it and we should audit it. And this will help us in documenting the safety as well as the risk for our future blocks. And we can also counsel our patients or based on our own practice rather than literature that this block carries this much risk. We should always train our juniors and keep ourselves also abreast with the latest literature to be safe at all times. However, neonatal age group, the pediatric regional anesthesia practice still needs much more research is needed to be done in the field of neonatal regional anesthesia. So thank you very much. I like to conclude by saying that pain is inevitable, but suffering is optional. So it is our moral responsibility to keep our tiny tots happy. Thank you very much.
Greetings to all on the occasion of the first World Week of Regional Anesthesia and Pain Medicine. As anesthetists, we know that regional anesthesia is a safe option for our patients. My talk on mitigating nerve injuries during blocks is being made with the intention of making it an even safer practice. I'm Dr Anjolie Chabra from AIIMS, New Delhi. The incidence of peripheral nerve injuries is extremely rare and it's difficult to estimate the exact incidence. But what we should know as anesthetists that peripheral nerve injuries are 9 times more likely to occur due to surgery or due to patient-related factors rather than to the nerve block. And there can be 2 types of neurological deficits. There can be either post-op neurological symptoms or permanent peripheral nerve injuries. The postoperative neurological symptoms, they consist of paresthesia, tingling, numbness, some sensory symptoms that are seen in the early postoperative period. Incidence is relatively high from 8 to 15%, but luckily they rarely progress to permanent neurological deficit. With passage of time, there's a decrease in the incidence of these symptoms. So at 3 months, the incidence may be 2%, whereas at 6 months, the incidence is 0.8%, and at 1 year, the incidence may be 0.2%. Reassurance and constant follow-up of the patient is very, very important and results in a good outcome. The incidence of permanent nerve injury was assessed by the Australasian Regional Anesthesia Collaboration in 2009. They prospectively followed up 7,000 patients who had received nerve blocks. 13% received blocks under ultrasound guidance, 30% under peripheral nerve stimulation, and 50% under a combination of both the techniques. The remaining were miscellaneous. Out of these 7,000 patients, only 30 patients, that is 0.5% patients, needed a neurological assessment to ascertain whether they developed nerve injury. They had symptoms which were suggestive of nerve injury, so they were evaluated. And out of these 30 patients, only 4 patients, or 0.04% patients, were found to have permanent nerve injury. The ESRA Practice Advisory 2015 also states that the incidence of permanent nerve injury following blocks can vary from 0.04% to 0.14%. So there is a very, very low incidence of permanent nerve injury. But what is to be noted is that there has been no apparent decrease in the use of these nerve injury incidents with the use of ultrasound for regional anesthesia. Now coming to the structure of the nerve, the smallest unit of the nerve is the axon, which is covered by a myelin sheath, and a number of these myelinated axons are collected together to form fascicles. These fascicles are enclosed in a tough covering called the perineurium, which protects these fascicles from injury by chemicals or mechanical injury. A number of these fascicles are enclosed together and they're enclosed by a relatively porous and permeable layer called the epineurium, which is the covering of the nerve. Now, classification of injuries depends upon the extent of injury. So if only the myelin sheath is damaged, it is called as neuropraxia, and here nerve conduction is present but it's slow, and the patient will have spontaneous recovery within days to weeks. However, if in addition to the myelin sheath there is also damage of the axon, that is known as axonotemesis, here nerve conduction may not be present and recovery will be slower, and recovery may occur over weeks to months. Further nerve injury, which involves damage to the perineurium, the endoneurium and the epineurium, it may result in permanent nerve damage, which will require surgical intervention in the form of grafts to repair the nerve injury. There can be various mechanisms of injury. There can be mechanical factors such as excessive pressure during injection. There can be pressure factors, that is use of tourniquets at very high pressures, which can cause ischemia by interfering with vascular supply of the nerve. So and there can also be patients who are on anticoagulants who develop hematomas, which can cause pressure effects, and there can also be chemical factors in the form of the local anesthetics and adjuvants that are injected to produce the block. All these factors can contribute to nerve injury. Now, as far as injection under pressure goes, we have a photo of the electron microscopic photo of the nerve on the upper right corner. This has been taken from the ESRA website, and as you can see that the fascicles are suspended in adipose tissue, and there's also blood vessels and lymph in this stroma of the nerve, and the nerve is covered by the blue colored epineurium. It has just been colored for marking purposes. So an intraneural injection can occur when the needle pierces through this epineurium, but it can still be an extrafascicular injection. That means the fascicle is not entered. An intrafascicular injection occurs when the perineurium, as I had described to you earlier, is breached by the needle. So the most dangerous injections are the intraneural intrafascicular injections, and they are all the more dangerous and result in nerve injury if the injection has been done under pressure. So this should be avoided at all costs. Now, needle tip design can also contribute to the extent of nerve injury. We prefer to use blunt tip needles because there's less chance that they will pin and transfix a nerve. But in case they do, the damage caused by a blunt tip needle is more extensive than that caused by a sharp needle. However, we still prefer to use blunt needles for doing nerve blocks. Local anesthetics per se are neurotoxic. lignocaine is more neurotoxic than bupivacaine, which is more neurotoxic than ropivacaine. This has been proved on animal studies. And local anesthetics also have the potential to cause vasoconstriction, which can decrease blood supply to the nerves. Levobupivacaine causes more vasoconstriction than ropivacaine, which causes more vasoconstriction than lignocaine. Toxicity of local anesthetics is more at higher concentration, as has been seen with the cauda equina syndrome, which was observed with the use of 5% lignocaine. Adjuvants to local anesthetics can also contribute to neurotoxicity. Ketamine and midazolam are not recommended because they are neurotoxic. Neostigmine has a dose-dependent neurotoxicity, and it should not be used in doses of more than 50 mics. Dexamethasone and dexmedetomidine are the only two adjuvants which are thought to be neuroprotective. Adrenaline is commonly used as an adjuvant to local anesthetic administration to prolong the duration of action, and this it does by causing vasoconstriction, but it can also decrease the neural blood flow, and this is more so in patients such as diabetics, hypertensive, and smokers who already have a precarious blood supply to the nerves. And the effect of adrenaline on decreasing blood supply is dose and concentration dependent. So a dose of 2.5 mics per ml might actually increase transiently the blood supply to the nerve, but in doses of 10 micrograms per ml, there's a 35% reduction in the blood supply of the nerve. And when a local anesthetic such as 2% lignocaine is used with 1 in 200,000 adrenaline or 5 mics per ml of adrenaline, there is an 80% reduction in the blood supply of the nerve. So a word of caution, none of the adjuvants that are listed have been licensed for perineural injection. So we're using them at our own risk. Now, the factors that increase the risk of peripheral nerve injury, patient factors we've already spoken about: diabetics, hypertensives, patients on anticoagulants, patients with vasculitis, uremia, and demyelination are more likely to have nerve injuries. Now, there are certain surgical factors also associated with more incidence of nerve injury, and this is seen more likely with orthopedic surgeries, especially major joint surgeries, and the neurological injury is severe even if the surgery is done arthroscopically. Then if the patient already has a pre-existing neurological deficit, then administration of local anesthetic can lead to a prolongation of the block and can also lead to permanent nerve damage. This phenomena is known as a double crush injury, so we should be careful in patients with pre-existing nerve deficit. Consensus guidelines recommend that we should do blocks in awake rather than asleep patients. This is because in awake patients, they can warn us by telling us that they are having paresthesias. They can either have some tingling sensation or they can have some sensation of a current passing through, and this should warn us, and in case paresthesia occurs, we should stop and reposition the needle. More chance of post-op neurological symptoms occurring with paresthesias rather than permanent nerve injury. However, paresthesia should never be elicited and they should always be avoided. To prevent nerve injury, it is recommended that triple monitoring should be done. Peripheral nerve stimulation, ultrasound, and injection pressure monitors should be used. The ultrasound helps us to identify an intraneural injection because the size of the nerve increases if we are injecting intraneurally, but the resolution of the ultrasound is not adequate to distinguish between an intra and an extravascular injection. And like we've already discussed, it is not the intraneural injection which is dangerous, but it is an intervascular injection which is dangerous. Nerve stimulation can also be used to identify whether we are intraneural, and if at 0.2 to 0.5 milliamperes current of which is administered for 1 millisecond, a motor response is elicited, it indicates that it is an intraneural injection. This is specific but not sensitive, because in a number of animal studies it has been found that even with the needle tip being intraneurally, no motor response was observed. Injection pressure monitors can also be used because ascertaining pressure by digital methods is not standardized. There are a number of injection pressure monitors: Be Sure, there's a Safira monitor, and there's a nerve guard. All of these injection pressure monitors recommend that injection pressures in excess of 15 psi should not be used, where 1 psi roughly equals to 52 millimeters of mercury. In case we do not have injection pressure monitors, Sui has recommended using compressed air injection technique. Here he used 10 ml syringes and 5 ml syringes and filled them half with air and half with fluid, that is water, and then he compressed the plunger to 50% of its capacity needle. He found that an absolute pressure of 1520 millimeters of mercury is created at the tip of the needle. If we subtract the atmospheric pressure, that is 760 millimeters of mercury, from this absolute pressure of 1520, the pressure at the needle tip is estimated to be 744 millimeters of mercury, which is far lesser than the threshold pressure of 1293 millimeters of mercury, which has been found to be associated with clinically significant nerve injury in animals. That these experiments have been done in dogs. So now, if you have a patient who is complaining of nerve injury, how would we know? The patient might have new onset pain, they can have numbness, they can have abnormal sensation which lasts beyond 48 hours of a single shot block. In case one encounters such a patient, one should review the medical records and one should observe them, examine them, and record all our findings. If the symptoms are mild and they start resolving, then one can follow up the patient, keep reassuring them, and review the patient at 4 weeks. However, worrying symptoms are if the loss is complete, if it is progressive, if the neurological deficit consists of loss of motor power, then it is worrisome, and one should inform the surgeon and the concerned anesthetist, and one should consider doing nerve conduction studies, EMG, and also neuroimaging, and patient should be followed up. If the symptoms persist, then a neurology opinion should be taken. It can be taken at the outset also. And in case there is no improvement, even on repeat monitoring, then the patient should be referred to a neurosurgeon for surgical repair, such as nerve grafting. All through this time, physiotherapy and follow.
Good evening, everyone. Best wishes to all of you on first World Regional Anesthesia Day. At the outset, I would like to thank Dr. Sandeep Diwan sir for giving me this platform. To start my presentation on prevention of conversion of perioperative pain into chronic post-surgical pain, I would like to present two cases. First one is 38-year female underwent right-sided radical mastectomy under general anesthesia. Fentanyl was used perioperatively for analgesia, and post-operatively PCM intramural was used. Later on, she developed hypersensitivity, allodynia, swelling of the right upper limb with current-like sensation. She was depressed and lost interest. Second case was 42-year-old male underwent below knee amputation after crash injury under spinal anesthesia, and post-operatively he was having a severe pain in stump region, right lower limb with pricking sensation. So a few questions comes into my mind, whether that post-surgical pain is a sequelae of inadequate pain management, and can we prevent it, and if yes, how we can prevent this. So I'll discuss my talk on following heads. What is acute perioperative pain management? Why adequate management is important? How you can manage this effectively? What are the various reasons for lack of adequate pain management? What are the consequences of inadequate pain management? What are the physiological basis of chronic post-surgical pain? What are the associated risk factors? And can we prevent? What are the preventive measures? So acute perioperative pain management is a mechanistic approach of managing pain before, during, and after surgery that are intended to reduce or eliminate post-operative pain based on current understanding of peripheral and central mechanisms involved in nociceptive transmission by preventive analgesia and multimodal analgesia. The perioperative pain is acute and mostly nociceptive in nature. It is related to easily identifiable event. It warns ongoing tissue damage. It's a symptom of disease process experienced in and around that injured tissue. It is associated with minimal psychological symptoms and mostly self-limiting within few days to week, with healing within 1 month. Irrespective of whether it's somatic or visceral pain, the pain is transmitted from periphery, from the site of injury to the brain by afferent nociceptive pathway and efferent modulating pathway. So there are 4 basic elements of pain processing: transduction, that is whenever any nociceptive impulse or any sort of injury is there at the site, it leads to generation of action potential. This is transduction. This action potential is traversed by a first order, second order, and third neuron to the brain. This is transmission. And this pain impulse is modulated. Either the intensity of the pain or the intensity of the pain is increased or decreased. This is called modulation. This is by this descending pathway. And finally, the perception of the pain at the central level. So most of our traditional approach of managing analgesia is targeting this perception part. In case of visceral pain, this is usually because of the distension, ischemia, inflammation of that viscera. And it is poorly localized, associated with nausea and autonomic disturbances. Mostly spasmodic in nature, and it is referred. But the pathway of afferent pain, nociceptive pathway, and efferent modulating pathways are the same. To have successful perioperative analgesia, we should provide adequate depth of analgesia to block all the nociceptive inputs during surgery. It should be extensive enough to include entire surgical field. It should provide adequate duration of analgesia that includes both surgical and post-surgical period, and should be preventive so that we have to give analgesic remedy, whatever we have decided, before the implication of that injury, before the start of the surgery. And most of the study has shown that if we started before the injury, then the impact of that analgesia is much more better than when we started after the surgery. Secondly, it is very important how to assess the pain. So we choose a one tool scale that should be used throughout the perioperative period, because if you use multiple assessment scale, that will give inappropriately high or low scoring of the patient's pain, as different metrics are used in different validated scale. And after the assessment, you have to choose a multimodal approach to manage these pain. That includes pharmacological therapy and non-pharmacological therapy. Pharmacological includes opioids, non-opioids, adjuncts, and regional techniques. And non-pharmacological involves cognitive behavioral intervention, that in the form of explanation, reassurance, discussion of analgesic options, relaxation, distraction technique, music, and imaginary therapies. And physical intervention includes splint, massage, heat and cold application, acupuncture, and TENS. But always remember that should include preventive policy and multimodal analgesia. And it should cover all the aspects of the pain, including that cognitive, psychological, social, and that nociceptive part. So the current understanding of peripheral and central mechanisms involve role of multimodal analgesia and combination of analgesic and this analgesic which acts at a different analgesic of different class, which acts at a different level of these 4 elements which I have already discussed. All the 4 elements of the pain processing. And as I said, that the traditional approach in targeting only the pain pathway and the pain processing. So we have to target either at the drug should act at the inhibition of prostaglandin synthesis that may inhibit sodium and potassium channel, calcium and neurotransmitter release, or that can inhibit serotonin norepinephrine uptake, that can inhibit opioid receptors and NMDA receptors. So we have to use drugs in such a way so that it will affect all the, it can target all the 4 elements of pain processing. The WHO, the traditional WHO letter is, it has 3 steps and it's in increasing order. We can move from step 1 to step 3 if the pain persists or worsen. But the recent new adaptation of analgesic letter is, it is in both the direction. So according to the, depending on the pain and its response to treatment, we can go either step 1 to step 4 or step 4 to step 1. They have also included step 4 as interventional treatment. So this is how we can give successful perioperative analgesia. But while choosing multimodal analgesia, what are the factors that determines that you should keep in mind? That is the type of the pain, whether it's nociceptive or neuropathic. Nociceptive pain usually best respond to opioids, RNS, NSAIDs, and PCM, and regional technique. But neuropathic pain, we need to add non-opioid analgesic agents such as NMDA receptor antagonist, alpha-2 agonist. We have to consider end-organ function while choosing any drug, non-opioids and opioid requirement, whether patient, what is the requirement. If patient is taking it before surgery, then that should be keep in mind. Whether escalation is required, what are the associated predictors and risk factors. So why this adequate acute perioperative pain management is important on humanitarian ground? Because pain is the 5th vital sign and pain relief is a basic human right. We have to overcome the surgical stress response and early complication. It is for the faster recovery, improved patient satisfaction, comfort and quality of life. We have to facilitate post-operative healing, ambulation and rehabilitation. And of course, we have to prevent long-term suffering in the form of persistent chronic post-surgical pain. And lastly, but not the least, is the building trust on effective acute pain services of our institute. So, managing acute perioperative pain is just like a butterfly effect. It is widely popularized and used in various fields beyond science, such as philosophy, literature, and popular culture. It says that insignificant action, minor action, can have a profound and widespread effect over a time. And it was first described by Edward Norton Lawrence in 1960. So if you won't treat it, this minor element of perioperative pain management can have a big impact in the form of chronic post-surgical pain. So what are the consequences of inadequate perioperative pain? That is immediate and long-term effects. So immediate effect during perioperative period, if that inadequate pain is there, that leads to surgical stress, release of cytokines, adverse neuroendocrine and cytoadrenal response, detrimental physiological responses, and that affects each and every organ, and that delays recovery, that may affect cardiorespiratory system adversely, increases risk of post-operative ALS, increase the risk of oliguria and urinary retention, impair immune system, that leads to delayed wound healing. There is increased risk of thromboembolism and so many effects on organ system. A long-term consequences of inadequate perioperative pain management is increased psychological stress, delayed ambulation and return of function, higher readmission rate of around 38%, increase overall cost of the care, and there is risk of chronic post-surgical pain. So what is the burden of chronic post-surgical pain? Data suggests more than 300 million people, patient undergo surgery worldwide each year. And this number is increasing day by day. And the prevalence of moderate to severe post-operative pain varies worldwide from 30 to 80%. The most common concern after surgery is post-surgical pain. That is common in 56% of the patient. And many psychological factors, anxiety, depression, fear of death, expectation of pain, associated sleep deprivation, age, obesity, they all affect the postoperative pain control. So it is usually there is an individual variation in occurrence of chronic post-surgical pain. But besides knowing all these, because besides availability of all this many analgesic regional techniques, still the perioperative pain management is inadequate. Why it is inadequate? But there is no precisely known reason for this, and data are very conflicting and confusing. But some says that the appropriate adjuvants like simple analgesic and anesthesias are often overlooked. Irrational selection of analgesic from limited number of available options may be a cause. Lack of clear guideline regarding appropriate combination of analgesic for a specific procedure. Sometimes physicians over-concern about the drug addiction, so they prescribe less. Sometimes patients receive fewer opioids, even after ordered by the physician. Inadequate knowledge of the nature and properties of the selected analgesic, predictors, and high-risk surgeries. So what is chronic post-surgical pain? It is the pain of greater intensity and different characteristic than the preoperative pain. Sometimes it can be a continuum of acute perioperative pain that persists beyond 3 months after the triggering events. It is included in this international classification of the diseases as ICD-11. It's a complex biopsychological phenomena. The median incidence at 6 to 12 months after surgery is 20 to 30% with slight decrease over a time. The incidence vary with the type of the surgery because the healing process is different in different surgeries, and it's of course a clinical and socioeconomic challenge. So what are the basis of this post-surgical pain? There are peripheral sensitization, central sensitization, neuroplasticity. These are the basis for development of this post-surgical pain. So what happened whenever there is tissue injury, there is activation of nociceptive nerve endings and local inflammatory cell that causes release of substance P and glutamate from a small nociceptive afferent that leads to stimulation of inflammatory cells and further release of allogenic substances that is known as sensitizing soup. This causes increased excitability of the nociceptors. So this leads to peripheral sensitization and primary hyperalgesia. That is the hyperalgesia at the site of the tissue injury. Because of this repeated firing of the C fiber, what happened? There is release of glutamate and substance free from the peripheral nerve that removes the magnesium block at the NMDA receptors that leads to calcium influx. And this calcium influx leads to excitability of WDR neurons and dorsal horn and subsequent wind-up phenomena. There is increase in receptive field size, and this leads to central sensitization and subsequently secondary hyperalgesia, that is hyperalgesia at the surrounding tissue, surrounding to that injured tissue, and allodynia. Then because of this continuous firing and because of the growing of more connections to central order neuron within the CNS, because of this calcium influx, this leads to many of these neuroplastic changes inside that leads to dying of that inhibitory interneurons, remodeling of the glial cell to that intensify nociceptive transmission, and these pen transmitting neurons become more and more sensitive and they react more intensively to the stimuli, and there is growing of more connections to the second order neuron. So these neuroplasticity may be a cause of development of this chronic post-surgical pain. There are many risk factors that you have to keep in mind and that may be patient related, anesthesia related, surgery related, and it's pain related itself. If pain related means if patient is already having pain before that surgery, a patient is already on opioids, then chances of CPSP is more. if surgery of prolonged duration, if repeated surgeries are there, surgery patient underwent repeated surgeries, certain type of specific surgeries, they are prone for CPSP. It has been shown that more of the opioid use and under general anesthesia, the CPSP is more. And certain patient-related factors like young age, female sex, smoking, history of depressive symptoms, history of anxiety, sleep difficulty, if patient is obese, presence of preoperative pain or preoperative analgesic use is there. In case of psychological distress, then these patients are at risk. Certain surgeries, as I mentioned, amputation, thoracotomy, mastectomy, inguinal hernia repair, sternotomy, cholecystectomy, abdominal hysterectomy, saphenous vein stripping, LSCS, craniotomy, nephrectomy, they are prone for CPSP. So what are the preventive policies available to prevent the CPSP? Most important is effective perioperative pain management is very, very important. That should be individualized and should be multidisciplinary. That includes pharmacological and non-pharmacological measures, and it should cover all the 4 targets of vein processing. The numerous pharmacological studies have investigated the effect of preventive strategies on the development of CPSP, but the results are disappointing and inconclusive. But one should reduce the use of opioids as far as possible because of tolerance and because of opioid-induced hyperalgesia. So you should avoid opioid as far as possible because opioids facilitate central sensitization by various techniques, which I have already discussed. So there are certain studies that they are studied on ketamine, effect of ketamine on prevention of CPSP, but they found that can be used in high-dose opioids before surgery if patient is on high-dose opioids, but no definite effect was found on prevalence of CPSP after 3, 6, and 12 months. So the effect of ketamine on CPSP are currently inconclusive. Certain studies have also studied gabapentin for prevention of CPSP, but one of the meta-analysis showed no definite effect of perioperative use on incidence of CPSP, but it can be tried in neuropathic pain in certain patient who is undergoing procedure associated with nerve damage, such as complex spine surgery. IV lidocaine, there is no clear-cut recommendation, but one of the studies that suggests lidocaine IV for 24 hours potentially helps to reduce CPSP in patient undergoing breast surgery. Other drug, duloxetine, has been tried, but clonidine, dexmedetomidine, nifopin has not yet been studied adequately. So there's no recommendation for the use for prevention of CPSP. Regional analgesia, of course, it reduces the risk of CPSP in various types of surgery studies so far, but level of evidence are very low. In most of the studies, they have used only the single shot procedure. But although if these studies can be done in a long duration, for these procedures are used for a long duration, that might increase the effectiveness of these regional techniques for prevention of CPSP. Non-pharmacological methods are also used for the prevention of CPSP, but the evidence are very less and no RCTs are showing their effectiveness in this process. But that can be utilized because chronification of the pain is not only a biological, but also a highly individual process involving psychological and temporal aspects. There comes the role of non-pharmacological interventions. So to summarize, we have to assess the risk factors, patient-related, surgery-related, pain-related, and anesthesia-related risk factors during PSC, and you should give preventive analgesia, multimodal analgesia, use multidisciplinary approach at the time of surgery, during surgery, and after surgery, and by that we can prevent. We can prevent if we target all the 4 elements. We can prevent conversion of this acute perioperative pain into post-surgical pain. So the take-home message is Adequate perioperative management should be a priority to avoid long-term consequences in the form of post-surgical pain. One has to manage acute pain aggressively and should start before the surgery. Early identification of risk factor is important. The therapy or strategy should be individualized. Multimodal analgesia is the key to minimize desirable effects and minimize side effects. And always select a pain mechanism specific medication and peripheral central neural blockage rationally and target all the 4 elements of nociceptive processing. Thank you so much. Greetings from my institute, Pandit Jawaharlal Nehru Memorial Medical College, Raipur.
Good afternoon, everybody. Welcome to Anaesthesia TV. I'd like to present a small talk on how do I improve my blocks. I'm Dr. Chaitanya, consultant, Rainbow Children's Hospital, Bangalore. The seminar may last only an afternoon, but the inspiration could last a lifetime. Now, why do I fail? Why can I not see my needle? Although ultrasound has given us the ability to visualize both anatomical structures of interest and the block needle, still we fail. Ideally, ultrasound should also equate to greater efficacy and improved safety, avoiding unintentional intraneural and intravascular punctures and injection. The anatomical identification becomes easy, but then still I cannot see where my needle is. The most common error in practitioners is missing the needle tip. Some of us can see the shaft of the needle or only part of the needle, but we cannot visualize our needle tip very well. The needle advancement and/or local anesthetic injection without adequate needle tip visualization may lead to unintentional vascular, neural, or visceral injury. What do I do next? Optimize the imaging. Get to know your ultrasound machine. The ultrasound knowledge changes from a company to company and across various models. So know the ultrasound that you're using much better. Have the ergonomics optimized. See that you're on the right side. You're comfortable doing the procedure. Patient is comfortable and the ultrasound machine is at an eye level and you need not turn every time to do a block. Optimize probe handling. Stabilize the probe. Most of them, when they are doing a scout scan, land up doing a scout scan with the right hand, learn with their dominant hand. But when you're doing the procedure, you are scanning with your non-dominant hand and doing the needling with your dominant hand. So practice with your non-dominant hand. See that your non-dominant hand is stabilized somewhere and does not fatigue easily while doing the block. Have a lower and needle of the angle so that you can visualize the needle much better. I have done all of this, but still I cannot see my needle. So what next? We have few newer technologies to our rescue, thankfully. How can we see the needle much better? The most important and the most easiest one here are echogenic needles. Echogenic needles are laser-etched or corner cube reflector needles. The edges reflect the ultrasound beam back, creating a brighter echo on screen. Using an echogenic needle can negate the need of adding expensive other equipment which can have beam steering, etc. So this is typically an echogenic needle. You can see that there are edges marking at the tip of the needle, near the tip of the needle, which causes reflection in the ultrasound beam back. So this is an ultrasound image of the echogenic needle, how it is seen when we scan. Only the distal part of the needle have these echogenic markings. So you also can assess your depth. So there is a safety code. The tip has a marking, so you can see the tip triangular. Then there are two short markings like a Morse code, and then there is a long marking. So it also gives you the distance and the depth and whether you're in the ideal position or not. Various companies have different kind. So the B. Braun has the Stimuplex Ultra and the Ultraplex. Stimuplex Ultra, where there is an ecogenic tip along with the stimulating capacity, whereas Ultraplex only has the ecogenic needle and no stimulating capacity. They also have something called the Contiplex Ultra or the Contiplex 2E. This is a stimulating needle with microdot stimulation at the electrode tip. There are also ecogenic etched markings designed for enhanced ecogenicity. It has a side port valve where you can inject and aspirate and then thread the catheter without needing to disconnect or move the needle. It has a closed tip. The catheter has a closed tip of 20 gauge with the 39 polyamide nylon catheter. It is highly visible atraumatic catheter. There are 6 openings in the catheter, which is you can see here, which are perfectly visualized and perfect for the spread of the local anesthetic. There is something called the Havel's EcoStim, which is an insulated needle. This is for ultrasound blocks and for pain injections. There are 4x4 corner cube reflectors, they are patented corner cube reflectors, which provide multiple angle surfaces where the reflection of this eco beam can occur. They also have a Havel's EcoBlock needle, which is a non-insulated needle. Here there is micro laser etching at the tip to reflect the sound waves back to the transducer. It does not indent the cannula, so it has a stillet since the inner diameter is not affected. It is also completely encircled at the tip of the needle. So whichever angle the needle is, still there is enough reflection of all the ultrasound beams. They also have a similar laser etched 2E needle, which helps us in placing the catheters. Payung also has multiple options. They have the Sonoplex Stim Cannula, Sono Tap Cannula, Sono Eye Cannula, 2E Sono Cannula with metallic stillet, and the ECAT system. That is the catheter over needle system. This is something very particular where they have, if you can see here down in the image, the needle is inside the catheter. The catheter is slided out on the needle. So there is no need for disconnection and reconnection causing displacement of the needle. Now, what is the evidence to invest in these ecogenic needles? So there have been multiple studies, I will quote a couple of them, where there is a comparative evaluation of the visibility and block characteristics of a stimulating needle and catheter versus an ecogenic needle and catheter for sciatic nerve block with a low frequency ultrasound probe. Now, they found that ecogenic needle and catheters reduce the procedure time and patient discomfort because you're not requiring multiple passes, you're not taking up too much time when compared to the stimulating catheter system. Needle ecogenicity in sonographically guided regional anesthesia. It's a blinded comparison of 4 different enhanced needles and validation of a visual criteria for evaluation. In these results, I have given you the references. You can go refer further. In these results, they support the idea that all ecogenic needles designed do not uniformly enhance the needle visualization. And further studies are needed to determine whether needles with superior tip clarity predict not only clinical preference, but also improved sonographically. Basically, they meant not all ecogenic needles are same. Some perform better, some perform lesser, and also there is a user bias. So compared to a novice, an experienced person may require fewer passes even with ecogenic needles. There's also, that is coming to the needle. Now, what can we change with our ultrasound probe? We can use needle guides. There are in-plane needle guides or out-of-plane needle guides. In-plane needle guides go on the side of the transducer with through which you can pass the needle, and so that the needle remains in line with the probe at any time. Out of plane also does the same thing. You locate the target area, place the needle through the needle guide, and there is no displacement of the needle throughout the procedure. Now, there are software developments which are done in the machine which help us visualize the needle better, which is also known as compound imaging or beam steering technology. Here, it combines 3 or more images from different steering angles into a traditional single image. So traditionally, transducers send ultrasound signals in a single line of sight. With compound imaging, the ultrasound sends signals at multiple angles, allowing it to see the tissue from multiple angles and eliminate the artifact. So this is how one sees in beam steering technology. The ultrasound can steer the beam so that it reflects more perpendicular to the needle, and visualization of the needle is improved dramatically, almost as though the needle tip lights up. So this is also known as cross-beam technology, CRI, sono-CT, I-beam, etc., etc. Different machines call it different. There's also something called the sonic GPS. I personally haven't used these. The sonic needle guidance position system basically uses a GPS, and it clearly predicts the needle trajectory during invasive procedure. So once the marking is done, you predict where exactly you need the depth, and it will tell you through which trajectory you will get much better approach to your target. So the intersection between the ultrasound image and the needle on its projection line is marked as X, and it will tell you which exact direction you need to go, how much you need to angulate your needle to reach the point X. Now it works both in plane and in out of plane. Once the target is fixed, enter the patient with the needle without moving the transducer any further. Now, real-time ultrasound guided spinal anesthesia using sonic GPS ultrasound guidance system. So they concluded that it simplifies the real ultrasound guided spinal anesthesia to a large extent, especially when done out of plane. However, it is a complex multi-step procedure that requires time, specialized equipment, and working knowledge of the spinal sonoanatomy. Next, what can we have next? We are in the era of ChatGPT and artificial intelligence. So there is use of artificial intelligence in regional anesthesia as well. This is one such study. There are multiple studies, I'm not going to quote them all, where they have taken the recent advances in AI and used it for regional anesthesia. Now, just broadly understanding. So there are different software systems. So this is the ScanNav. So basically what you do is once you place the probe over the tissue of interest, the ultrasound image is studied by AI, and they do figure out and they do give you a side-by-side image of what these structures are and where your targeted nerve is and what should be your trajectory. So prior to this, the system has loaded software and multiple images of these nerve blocks, most common nerve blocks. So it helps you identify the structures much better. It helps you guide your needle to the structure much better. So this is a picture of the saphenous nerve block above, and below is the picture of an interscalene nerve block where the muscles get highlighted and they are labeled accordingly, and it tells you where exactly you need to go. In the second one, which is called the nerve blocks AI technology, it will also predict how accurately you are blocking the interscalene nerve. So prediction as you're doing the needling and giving the local, it will give you a prediction as to whether you your block is going to be successful or not. So you need not wait for that 20 minutes for it to act and for us to be sure. You can be sure right on the table. This is in brief. All I'm going to tell you is that it's not going to be easy, but it's going to be totally worth it by putting your efforts and bettering our skills to the benefit of the patient. Thank you so much.
Welcome to this first World Anesthesia Day, a regional anesthesia day, and this topic is based on role of cadaveric in regional anesthesia training. I owe my gratitude to my friends George Fiegel, Xavier Sala, Shiva Prakash, and Mani, and they are from Austria and Spain and from India as well. So basically, we are looking into several type of cadavers. These are formalin-based, soft embalmed, fresh frozen, as well as fresh cadavers. If you look at it, you can literally flex, extend, and rotate the neck of the cadaver, and this has been a very peculiar feature of the thiel embalmed cadavers. So we are looking into the understanding of basic anatomy, investigating an important structure, projecting a new approach, investigate a clinical study, projection of hypothesis, and there are several things that can be addressed. For example, the anatomic barriers can be delineated. You can question a technique, explore a novel technique, and you can also correlate your cadaver and clinical studies as well. Let's start with the basic anatomy first, like inspecting the anatomical structures, evaluating the topographical arrangement of brachial plexus, for example, and then you anticipate the diffusion of an injected. If you take the interscalene as a model, this, as you can see here, this is the, on the left side, you can see the brachial plexus. The C5 and C6 form the brachial plexus. That's the supraclavicular nerve, which emerges from C4. These are the roots of the long thoracic nerve, which are coming through the middle scalene muscle. And the phrenic nerve, it lies on the anterior scalene muscle. So if you are positioning your needle tip at this particular point, there is a chance of phrenic nerve, which is 100% with 20 ml of 0.5% bupivacaine. But as you go more caudal, the incidence of phrenic nerve naturally decreases. However, another important thing is that the needle which moves in through the middle scalene muscle during ultrasound guided in-plane technique can traumatize these nerves as well as the dorsal scapular nerve. The transverse section allows you to identify what you can see on ultrasound. For this is the C5 root, that's the C6, C7, and C8, the subclavian artery, as well as which is sandwiched between the middle scalene muscle and the anterior scalene muscle. This is the investing layer of deep cervical fascia, and below this fascia is the scalene fascia would lie the brachial plexus. Now this is the first strip and the pleura underneath here. And you can see the local anesthetic when you inject at this particular point would seep more into the C5, C6 levels and less commonly to the C8 and T1 levels. So whatever you see on the ultrasound monitor, the same picture would you anticipate with the cross-sectional anatomy in the brachial plexus area. Now, the blue dotted area is the safe zone where you can position your needle tip and the local anesthetic injected can follow that particular path. When you look into the cadaveric clinical study, for example, in the thoracic epidural space, you will find that these are the nerve roots which are surrounded by the dural sleeves as they progress to form the intercostal nerve here. And we studied in one particular block where we injected in the paravertebral and found a lot of epidural diffusion of the local anesthetic. And this is particularly because a lot of these nerve roots in the thoracic area would be surrounded by dural sleeves around 8 to 10 centimeters beyond the intervertebral foramen. And it's quite possible for you to inject in the paravertebral area and have an extension of the drug in the epidural space, which can be seen with the axial CT, and then it can be seen in the coronal CT as well. This is the epidural space, and these are the nerves in the paravertebral area, which is bounded by the pleura, the costotransverse junction, and the foramen on the medial aspect. And this is the area for the paravertebral block. And while this is just beyond the costotransverse junction, while this is the area of the erectospinal plane block. Now, there are several mechanism of actions which mention that the erectospinal plane block, the local anesthetic moves into the paravertebral as well as into the epidural space. We studied in a couple of cases where we found that the mechanism of action is spread through the costotransverse foramen as well as the path of the dorsal rami from the erectospinal plane into the paravertebral and epidural space. Though this has not been a consistent scenario when we look into several of these case studies. Coming to the lumbar plexus area, we can see that the lumbar plexus is hosted within the psoas major muscle, and it is around 1.8 to 2.2 centimeters beyond the transverse process. And you can see the lumbar plexus elements as they move into the psoas major. This is the psoas compartment, while this would be the paravertebral area. So when you inject your local anesthetic at this point, there could be some amount of epidural diffusion. And at this point, if you inject, that becomes the erector spinal plane block at the lumbar level. So when you inject at the contrast at the level of the erector spinal plane, we found that the contrast extends into the lumbar plexus, and this stains the lateral aspect of the lumbar roots. This is the cross section. This is the coronal section. You can see the spinal cord and the lumbar root at this point. And these are the axial oblique and the axial coronal, which depicts the contrast in the close vicinity of the nerve roots. Investigating the most important structure, which is the brachial sheath. Now, this was demonstrated by a couple of studies way back from 83 and 87, and again Franco in 2002. What has been depicted that a single point injection of latex, it does break the velamentous septae inside the sheath of the brachial plexus, and the latex as well as the methylene blue dye, it moves on to all areas of the median nerve, the ulnar radial, and the musculocutaneous and the medial cutaneous nerve of arm. So when we studied the axillary area of the brachial plexus, we found that these are the velamentous septae, which are sent by the sheath, which is covering the entire neurovascular structure, and these can be easily broken up with injection of a local anesthetic agent. When you denude the velamentous septae, what you find are the nerves here, and you can see a lot of these nerves which are the part of the brachial plexus area, and these are the various nerves. This is the axillary nerve along with the circumflex axillary artery. This is the posterior cord which goes on to form the radial nerve as well, and that's the sheath of the brachial plexus. So a couple of these can be seen easily with ultrasound. When you inject your local anesthetic agent, you can see that this is the septa which is enclosing the ulnar nerve. This is one which encloses the median nerve, and this is the radial nerve. All these nerves are being engulfed with local anesthetic agent, which can move from one area to the other area as well. You can always investigate a clinical study. For example, we use 3 ml of C5 anesthetic block for the clavicle, and this we have already published this, where we insert the needle just lateral to the C5, inject 3 ml of local anesthetic agent here. We draw the needle and inject in the superficial cervical plexus area to anesthetize the supraclavicular nerves, and this particular technique we use for fracture of the clavicle. When we injected the same amount of latex in a cadaver with dissection, we found that it spreads almost linear flow from the level of C5 down until the superior trunk level, and in the cross section, it covers the root, and a separate injection in the superficial cervical plexus would soak all the supraclavicular nerves as well. Another area that we investigated was the infraclavicular brachial plexus, where we inserted the needle posterior to the artery. And when we did that, in this particular, you can see the injection of local anesthetic just posterior to the artery, which will anesthetize both the nerves, the all the three nerves, rather, the lateral cord, the posterior cord, as well as the medial cord. So what we did was we injected this in the cadavers, the latex, and what we found was very fascinating, where we injected at one single point here, just posterior to the artery, and you can see the fascicles of the posterior, medial, and the lateral cord all been engulfed along with the flow into the musculocutaneous area between the heads of the coracobrachioles. At the same time, dissection we would find that below the clavicle, it entirely engulfs the brachial plexus cords. It stains the axillary musculocutaneous nerve, the median radial nerve, as well as the roots of median and the radial, as well as the lateral cord. But this is around 20 ml of local, and which also migrates low down into the axillary area as well. That's the coracobrachioles. You can also investigate the anatomic barriers for the paraspinal space, which was questioned. Do we require so many injection points by this particular author from Turkey? And what we saw was that when we did the cadaveric sagittal sections, we found that there are just three spaces. One is the deep erector space, which is superficial to the intertransverse ligament between the two transverse process. The second is the costotransverse space between these two ligaments, the intertransverse and costotransverse ligament. And the third is the paravertebral space, which is beyond the superior costotransverse ligament. So your needle position is just above the intertransverse ligament, between these two ligaments in this space, and then beyond the costotransverse ligament in this paravertebral space. So you have just three spaces and three needle positions, and you really do not require many such injection points in a very small paraspinal areas. So these are the three areas where you can inject your local anesthetic. Then you can also do the injection of the injection into the PENG block, which is an enigma, and what this block could lead to can be easily seen from this particular injection study that we did. Now, when we injected green dye in the PENG area, which is superficial to the iliopubic eminence and lateral to the psoas tendon, around 20 ml, it literally stained the branches of the subcostal nerve, branch of the iliohypogastric nerve, and also the lateral cutaneous branch again of the iliohypogastric nerve, apart from the branches of the anterior division of the femoral nerve here, and the posterior division of the femoral nerve, the lateral femoral cutaneous nerve at this point in this particular case, and it also stained the obturator nerve as well. So almost all the nerves of the lumbar plexus are being stained by the PENG block. So it's the volume of the injected, which literally spreads and produces a pericapsular block, and it may not be a motor sparing block based on the cadaveric study, but we need to correlate with the clinical studies as well. So you can also explore a new technique, for example, the circumpsoas block that we have published, and apart from the other blocks with the clinical aim, which was the following for the cervical erector spine, the phrenic sparing elbow plexus, motor sparing circumpsoas obturator involving sacral erector spinae ventral diffusing. So these are some of the aims, clinical aims, which were being studied with the cadavers. So when we inject into the psoas fascia, so this is the psoas muscle in the suprainguinal area, and we deliberately inject just below the psoas fascia so that it goes medial, superior, and then it goes as well as lateral. We injected into the cadavers, as well as we injected contrast in clinical cases. And what we found in clinical case was, this is the catheter over the psoas muscle, and the spread is almost lateral, involving the lateral femoral cutaneous nerve, the femoral nerve, the obturator nerve, and going right almost into the sacral area. This was just 20 ml of contrast with local anesthetic agent. Now, if you inject latex, it is a similar spread. If you see, it's a similar spread along the iliopsoas muscle, and it goes right up to the site where the obturator nerve would be situated. So if you compare these two injection techniques, the clinical and the contrast, they almost produce similar picture results, where you can see the spread along the psoas and then into the pelvic area. Again, the same flow into the pelvic area as well. So you need to extrapolate to conclude, you need to extrapolate with the clinical cadaveric analysis as well. So thank you very much for your kind attention. Kazma?
Dear colleagues, dear friends, it is with great pleasure, privilege and honor that I inaugurate the first World Day of Regional Anesthesia and Pain Medicine. This is a newly launched initiative of the European Society of Regional Anesthesia and Pain Therapy, co-organized in close collaboration with all our sister societies, ESRA Pain Medicine, AFSRA, LASRA and AOSRA. And on behalf of ESRA, I would like to extend a heartfelt and a very warm welcome to all of you joining us today, to the enthusiasts and the participants on this momentous occasion that is marking the grand finale of the first World Week devoted to regional anesthesia and pain medicine that we all celebrated during the previous days. And I have to admit, I feel extremely proud but also very, very happy to announce that today, on this special day, in 130 cities across all continents, we unite all together, combining our individual strengths and raising our collective voice under the theme Joining Hands for a Pain-Free Future Worldwide. A very warm welcome to all the participating cities in the European territory, to the United States of America, to Canada, but also to all the participating cities in the countries of Latin America, Africa, Middle East and Asia. All of them are hosting on this special day either small face-to-face or countrywide online meetings with local faculty and national experts and under a similar scientific program. And I have to admit, I am fully optimistic that from this year, from 2024 and onwards, the World Day of Regional Anesthesia and Pain Medicine, celebrated the last Saturday of every January, will be the event to start our year for an updated perspective in our fields, showcasing the principal new techniques and highlighting any new developments in the fields of regional anesthesia or pain medicine. At this point, I would like to express my sincere gratitude to the event chair, Dr. Sébastien Bloch from France, and the organizing team from ESRA side. Without you, this activity could have not become a reality. Also, many thanks from my heart to the leaders of all regional anesthesia and pain medicine continental societies, the country coordinators and the city representatives worldwide, as well as the national scientific associations that have embraced our efforts during the preparation of this event. Your enthusiasm and devotion have been truly remarkable. You have been amazing. Without you, we could have not arrived at this point. Also, a special thank you to the local faculty that today are contributing their expertise, transforming this event into a platform for insightful discussions and shared knowledge. I'm sure you will agree, as we convene, we focus on the vital field of regional anesthesia, recognizing its pivotal role in effective pain management, but also acknowledging it as an important bridge towards global pain relief. What I would like to highlight at this point is that this day is more than an educational and training event in our specialties. It is rather a celebration of collaboration and of a collective commitment to advancing the fields of regional anesthesia and pain medicine. Why? Because together we aspire to build a future where pain is understood, managed, and ultimately minimized, fostering a world of wellness and comfort for all our patients. Thank you from my heart for being a part of this global event. Let's join our hands to create a pain-free future for everyone, everywhere. Welcome to this day of enlightenment, connection, and progress. I'm wishing from my heart to all of you worldwide in every participating city wonderful activities and a great attendance, with the promise to meeting you all in person very, very soon. Welcome again, and thanks a lot for your efforts and your continuous commitment. Enjoy the first World Day of Regional Anesthesia and Pain Medicine in all corners of our world.
Hi, I'm Dr. David Provenzano, and I'm currently the president of ESRA Pain Medicine. I would like to thank you for joining the first World Day of Regional Anesthesia and Pain. We are truly excited to work with our sister societies on this event, and we're very appreciative of the leadership of ESRA for setting up this great event. At ESRA Pain Medicine, our vision is to relieve the global burden of pain. That obviously cannot happen unless we all work together. I think this event symbolizes the desire of all the sister societies to work together to advance the science and appropriate deployment of regional anesthesia and pain medicine techniques to improve pain control worldwide. We will continue to participate and to push initiatives that enhance education in pain medicine. We truly hope you enjoy this great event, and thank you for joining.
Hi, everyone. From the Latin American Society of Regional Anesthesia, we welcome you to this first World Regional Anesthesia Day. This is a great day for regional anesthesia, but I feel it's a greater day for the world, a demonstration that people from all continents, people from different beliefs and cultures can join, not just to a common list of topics to discuss and to learn, but more important, we join in a common mission and vision. We all care about others. We care about their pain. We all share the will to do something to alleviate someone else's pain. This is the message I see all of you are sending to the world today. We stand together. Thank you for caring, and thank you for being here today. Y a mis hermanos latinoamericanos, gracias por su compromiso y por estar hoy día también. May you all have a great day. Que tengan una gran jornada.
Good evening. On the behalf of the African Society of Regional Anesthesia, I would like to welcome you all for the first week online for World Congress of Regional Anesthesia and Pain Medicine. I'm Dr. Izzat Aziz, the president of the African Society of Regional Anesthesia. In fact, ESRA, the European Society, has taken the lead to organize this with the sister societies. We are so excited in Africa because, as you know, it's so difficult for us to attend conferences abroad for some financial strains on our doctors in Africa. So this is really a great initiative. We are hosting all over Africa, and we are doing live from Morocco, from Algeria, and from Egypt. Actually, in Africa, we're so excited to the point that, for example, in South Africa, we have more than one city, about 6 cities. We have people attending and doing these workshops from all over Africa, from north to south to east and west. I hope you will enjoy the meeting, and I would like to see you soon. Hopefully you will enjoy the day. Thank you.
The member societies of the Asian Oceanic Society of Regional Anesthesia and Pain Medicine are extremely delighted and excited to take part in the initiative of the European Society of Regional Anesthesia on celebrating 27th of January as the World Day of Regional Anesthesia and Pain Medicine. Thanks to President Dr. Eleni Moka and Dr. Sebastian Bloch, the chair of the event, for organizing this. And I'm sure this will go a long way in propagating the usefulness of regional anesthesia practice in several parts of the globe. And we in the Asian Oceanic Region and Pain Medicine will share information about regional anesthesia to as many members as possible and make sure they inculcate the habit of using regional techniques in every single surgical patients whom they anesthetize, so that the patient gets the benefit of regional anesthesia in the perioperative period. Thank you so much.
So I will start with a quote I usually use when I train new residents. The job is not always that difficult. It's the communication with surgeons, nursing personnel, and patients which actually poses the most challenge. Unfortunately, when working day in, day out in an environment like the OR, anesthetists get used to the high-stress environment and not always understand how anxious a patient is. When this knowledge of the anxiousness is lacking, it's almost impossible to anticipate. So failure to communicate is a cause for a lot of litigation and complaints and closed claims. And I would recommend you to read this very interesting article on a failure of communication, a patient story, and you'll get the link here. It's an absolute must read, and it's a story about a patient whose communication failed in an obstetric case. So, can you teach us to become better communicators? Yes and no. Some people do have a natural knack to be good at communicating. They are extrovert but also introspective, having a deep knowledge of their own strong points and weak points. Of course, not everybody has these abilities. However, there are a couple of things you can train. The best training is experience. Gaining experience will get you more confidence. The more confidence you get, the more it will radiate to patients. And this explains why I think that it's very important to have a regional team which is experienced and not casual blockers who only block once in a while. And secondly, there are also communicating courses you can follow. However, I'm quite unsure how effective these truly are. And I've followed a couple of them and it helped me, but how much it can help you if you don't have a natural talent, I'm pretty unsure about. And when communicating with patients, you can certainly use 10 short tips and tricks, which I will give you here. If you use them, it will make a difference. And this is the next question. Those 10 tips and tricks are probably the main reason you are watching this podcast. So bullet point number 1, every patient is a family member. All patients should be treated as a good friend or a family member. It's an easy tip and trick, but it really helps you concentrate on what's important. How would you or your family would like to be treated, and how can you achieve that goal? Number 2, quickly assess patients' characteristics. When you enter a block room, you should be looking at a patient and immediately assess their status. Are they very anxious or not? Are they informal patients where you can have a really nice, easy, even a joke? Is the patient extremely defensive in his or her attitude? So every characteristic makes a set of a preset communication templates go off and helps you. Okay, number 3, become a leader. That's an easy one. You need to be a leader. Why? Because patients want somebody who they can trust. When you enter a block room or an OR, you have to have this aura of control and helpfulness and a strong sense of, I'm here for you, trust me. Okay, number 4, be wary when teaching blocks. Be very careful, not for everybody, not everybody works in a teaching hospital, but always be very careful when communicating when a resident is doing a block, not like saying, be careful for that, watch out, that's dangerous. Never do that. Take over when you feel it's unsafe and always only give positive feedback. So number 5, I think, continuous communication. So it just doesn't stop at a little bit of talk at the beginning and then just doing a block without talking anymore. Continuously, while you are performing your block, talk with the patient, and even after the block has set in the OR, talk with what a tourniquet does, that it can give some pressure, that they can feel touch and sensation, but will not feel pain. Very, very extremely important. So it's a continuous effort, so not just a 5-minute easy talk and then you're off. The next number, see and hear everything. Concentrated on a very difficult block? Well, yeah. But while you are concentrated, you should be hearing everything. Like, for instance, when you're doing thoracic epidural and you hear a decreased heart rate while you're performing a very difficult block, immediately ask the patient, are you feeling okay? Talk with your team, get atropine ready, maybe go to a lateral decubitus. So be there and see everything. So the next one, team communication, very important. We've been talking about patients, but it's not only about the patients, right? Be a champion, be the T in team, be a hero. Your nurse personnel will be so happy when you can lead a team and inspire them. So next one, safe and quiet environment, extremely important. No patient who is anxious wants to be blocked while in the next room people are cracking jokes and laughing right next door. So make sure that the patient is in a safe and quiet environment. And the next one is very closely related. So remove distractions. I always get my phone out of the way when I do a block because patients will say, are you 100% giving your attention here when you take like 3 calls while you're doing the block? No, so make sure you remove all distractions. And the last one is very, very dear to me, closed loop communications. I never want to see any drug errors. And, you know, talking with your personnel when getting a drug, when a test dose or getting ropivacaine, always use closed loop communication so no drug errors are possible. Thank you very much for these 10 tips and tricks. If you use them, you will be a much better communicator. Most of them we've already discussed in our tips and tricks. However, there are 3 specific cases: failure, complications, and mistakes, which should still be emphasized. Failure, when a block fails, and it does sometimes, it's very important to stop, communicate and explain that we can do something else. We can give other pain modality and offer a multimodal approach and explain why the block has failed. So it's extremely important to communicate and stop. Stop doing a block when it's not working. Your ego can recover, however, bodily harm caused by persistence may not. Secondly, when facing complications, be very active in communication. Do not avoid contact at any moment and offer multiple contacts if a patient is in need. And lastly, when mistakes have been made, like drug errors or wrong-sided blocks, it is important to always completely have open disclosure and never try to conceal it. Apologize, be humble, explain steps that the department will take in order to avoid things like this again. So over to the last question, is sedation a better option? So it's definitely not a pro-con debate on whether communicating or sedation is better. They both have their role to play. Sedation should never be used as an alternative for good communication skills. However, it should be used as an additive when communication skills alone is not enough. And I would use that in extremely anxious patients where just talking is just not cutting it. Thank you.
First, I want to say I think the future is really exciting. We have massive growth opportunities because there's so much yet to be figured out in this area. I think it's important that anesthesiologists help define the value of medical interventions that we offer for pain management. And value is a pretty simple equation, but it's also very complicated. So value is equal to outcomes over costs. But the devil's in the details. And so outcomes defined by who? The insurance companies, the government, the hospital, the surgeon, the anesthesiologist, the patient, or some combination thereof, because it's pretty easy to devalue pain medicine interventions or any medical intervention if you change the numerator definition a little bit. And it's also very easy to value something. And there's a subjective component to all this. But what my point is I think for the future to continue to be very, very positive for our community, we have to be at the table and we have to help define the outcomes that matter. And to put outcomes in context, you have to know something about costs. And this is an area that I'm really excited about because we're starting to get some submissions to the journal that are dealing with costs. So the costs are the denominator of that value equation. And costs are also very, very complicated because they could be hospital level costs, government costs, insurance costs, patient costs like premiums and deductibles. So it can be very, very messy. But at some point, we really have to try to understand what costs are factored into the interventions that we offer, because some things may be cost prohibitive. And we need to define that before it's a problem that an administrator, let's say, points it out. Now, historically in regional anesthesia and pain medicine, we focus on outcomes such as pain scores and opioid reduction in the short term, the PACU 12, 24 hours. And I want to say that is still incredibly valuable because when we're comparing new techniques, we need to know what's happening in the immediate perspective, because if we're not making a difference there, it's hard for us to imagine how that's going to do anything downstream. But what I'm hoping for the future of regional anesthesia and pain medicine is that we start to connect the dots to some of these larger outcomes that are very, very important to both patients and the population. Things like the chronification of pain, and we're going to talk about that in a second. Things like mortality, major morbidity, extended lengths of stay, readmission data. And I think that there's a lot of reason to think that the procedures we offer and the interventions that we offer can impact in a positive way on some of these important outcome metrics. And actually at my institution right now, we're looking at the thoracic epidural approach that we use under fluoroscopy in terms of length of stay in abdominal surgery patients. And we're seeing a huge signal in the reduction in length of stay in patients who have epidurals compared to those who don't for the same open procedures. So I think the future's really, really exciting because we are going to be able to, and I think we need to focus on, to some extent, these long-term outcome metrics or more health system-centric metrics. But I do want to stress that there's nothing wrong with studying the immediate experience that a patient has with respect to pain in the perioperative period. That's really, really important because we want to fast-track patients that are, let's say, at an ambulatory surgery center. We want patients to have a good experience. That should be celebrated too. All I'm saying is that we need to try to include some more things downstream. And I also want to make a plug for longer-term pain management through catheter-based techniques or new pharmaceuticals. The reason why this is important is that if we're going to have a protective effect that's going to be linked up to meaningful health outcomes, the analgesia probably has to last longer than 12 to 24 hours. And I think with ERAS programs and novel nerve blocks, we're going to be able to achieve some of that. But it's important, I think, for the community to think about longer acting analgesia. Now, I think this is a really, really big story because some surgeries like lower extremity amputations are actually associated with a striking high incidence of persistent pain. I've seen ranges between 30 and 85%. And obviously the human suffering and costs associated with the development of chronic pain are absolutely massive. And any ability that we have as a community to decrease the incidence would have large population health benefits. And having said that, of course, the lack of good outcome studies and the lack of agreement on how to measure the outcome has left us kind of in a gray zone. But in the first question about the future regional anesthesia, this is exactly what I'm talking about. We really need to try to focus on some of these type of outcome metrics, because if we can make a dent on population health problems, that's going to really be a legacy gift to the world and to our community. Now, what do we know? We know that a poor patient analgesic experience correlates with the development of new chronic pain. And we know that patient pre-existing factors such as mental illness also predict the chronification of pain. The question ultimately then becomes, and this is for the research community and the clinical community, if we optimize the perioperative pain experience, can we actually mitigate some of these risks? And it kind of has a nice biological basis because unmitigated pain may very well lead to an inflammatory process that essentially primes the peripheral and central nervous system that results in maladaptive neuromodulation. That's what we know as central sensitization. And I love my job as editor-in-chief because I get to work with some of the smartest people in the world around these topics of centralized pain. And this is just an absolutely fascinating area of thought and investigation. There was a somewhat dated systematic review, I think from 2013, in thoracic surgery that compared epidural versus no epidural and did demonstrate a reduction in the incidence of persistent pain with an odds ratio of about 0.33. And that's a pretty large effect size. However, I think most people are familiar with the Dan Sessler study that was published in The Lancet in 2019 that found no difference in chronic pain at 6 and 12 months, comparing paravertebral block and propofol to that of volatile and opioid therapy for women undergoing breast cancer surgery. So there's some mixed information that's already out there. I think the one area with the best evidence is in chronic pain and phantom limb pain after amputation. Brian Ilfeld has published in this area and has some pretty high quality data showing that amputees have clinically significant reductions in pain at 4 weeks and possibly beyond with regional anesthesia. And what's exciting about that is regional anesthesia is actually underutilized for amputation surgery on a international level, especially in the United States. So that's an area for potential growth and research. In fact, at my hospital, we're working on a quality improvement initiative where we're really intervening early on patients who show up with life-threatening ischemia that may end up in an amputation, and we're trying to advocate for more epidural and peripheral regional anesthesia. So I think that, the data is very complex here, and there's a lot of opportunity for further investigations. And I would like for us to be in this area to really try to establish whether or not the things that we do can actually prevent some of this chronification. And I have heard people argue that the patients who develop chronic pain after surgery are kind of biologically earmarked to it. So the correlation that you see with unmitigated pain or poorly controlled pain and chronification of pain is just that. It's a correlation. It's not a cause and effect. And it wasn't like there was something specifically that the anesthesiologist did poorly that resulted in that. Now, that's one view. That's kind of the contrarian view. But I think that we do have to tease out this cause and effect. And my gut instinct is, looking at the data that's out there and talking with leaders in this field, is that inflammatory priming of the central nervous system during that acute phase is really something that we could potentially intervene on. And I have actually personally witnessed the transition from acute to chronic pain in the clinical world, and it's really scary. And it really made me think that there's something that we should be able to do to help minimize that risk of transition, including ketamine therapies and other interventional approaches. So I'm really curious to get people's thoughts on that in this World Day of Regional Anesthesia and Pain, because this is a very, very robust area of discussion. I look back on my career and I realize that there's so many things, and I've already alluded to this in this podcast, that we don't know. And there's so many opportunities to make people's lives better as a pain physician. And when I say pain physician, I'm referring to both acute and chronic pain management. And so it's very, very clear to me that unmitigated acute and chronic pain has massive health and economic implications, massive. And we can play a role in minimizing those negative implications. You have an opportunity as a young physician to minimize human suffering through a combination of pharmaceutical, procedural, and behavioral interventions. And I think pain medicine allows the opportunity to fully engage in medical decision-making in both the perioperative and outpatient basis. It's almost the complete career. You have interventional aspects, you've got medical aspects, you have a phase of care that extends out for quite a long period of time. And if we want to push things out into the chronification and the chronic pain world, it goes on for a very, very long time. I was speaking to Steve Cohen, who's one of our executive editors, who I think most people know very well, just a brilliant chronic pain physician from Johns Hopkins. And he said that as it stands now, essentially nobody who presents to a chronic pain clinic returns back to work if they're unemployed because of chronic pain. And what an awesome opportunity for us as a community to try to target that and fix that, because work gives people value in their lives and decreases incidence of depression. And I think that if we can figure out a way to improve people's pain to a point where they can actually return to the work and contribute to society from an economic standpoint, that would be a giant coup for medicine. And the young generation has the ability to do that because we haven't been able to accomplish that yet. And I also think that a career in regional anesthesia and pain medicine allows one to be incredibly creative. And I reflect back on my career with the use of ultrasound. That's where I got involved. Image guidance. There was no term POCUS when I started. We had ultrasound machines where you could see the frame rate was so low that the image was shaking. And we started exploring really basic vascular relationships to nerves to help us back in 1999. And everything just kind of took off with some technological advances in the ultrasound machines. But being part of that innovation was so much fun. And there are so many opportunities like this, because I hear sometimes from the young people that, oh, everything's already been figured out. No, absolutely not. There is so much growth opportunity, and you'll have a new image guided system at some point. You will have artificial intelligence to help you. You'll have probably some version of X-ray guidance for a lot of things that you don't have now. So it's a creative, fun time, and there's a huge unmet need in pain medicine, which makes it even more interesting. So everything's on the table, and I think I would encourage anyone to consider a career in this area. So I'll start with the two-part series that was spearheaded by Dr. Michael Barrington on systematic reviews and meta-analyses. He was joined by several amazing co-authors, including Ryan D'Souza, Ananda Zen, Ed Masha, and George Kelly. And this all started when Michael Barrington was actually an executive editor with us at Raipur before he went to Anesthesia and Analgesia. We struggled with some of the quality of the submissions to the journal when a systematic review meta-analysis was being performed. And the reason why quality is so important in this area is because systematic reviews and meta-analyses actually drive clinical policy in best practice advisories. And if you get it wrong at the systematic review level, things are going to go wrong downstream, and that's going to actually impact on direct patient care. And so since both Michael and I were kind of type A people, we really wanted to get this right. And so we put that team together to try to set the standards for pain medicine about how we want these systematic reviews and meta-analyses to look. And then Michael got offered the spot to work with Anesthesia and Analgesia, and we just built a great relationship and said, why don't we make this as a joint venture between the two journals and get kind of both editorial boards to sign off on it, and it'll have an extra, kind of like legitimacy, and when it's endorsed by two important journals. And so so it all came together. It was a long project, and it's now available. And it's a wonderful guide for all people at all levels looking to produce one of these type of papers. And we have a part one, which is kind of an introduction to some of the key concepts, and then a part two, which really goes into detail into some of the advanced techniques of doing these types of investigations, such as meta-regression and network meta-analyses that are very, very complicated. And a huge shout out to George Kelly. He's one of our editors specifically for systematic reviews and meta-analyses, and he's added a high level of quality to our reviews. So I really, really encourage people to check this out, share it with your students, print it out, put it on the wall, because it has a wealth of information. Okay, so now the next one that I picked was a study that was published by Dr. Diwan and colleagues from the Thomas Jefferson University in Philadelphia, and it's the real-world study of intranasal ketamine for use in patients with refractory chronic migraine. It was a retrospective analysis, and what I wanted to mention to the listeners of this podcast is that RAPM supports all different types of study designs. We want randomized controlled trials because that's the gold standard when you're looking at interventions. But the reality is there's a lot of really good real world pragmatic data where we can learn about the therapies we're actually delivering currently. And what's really cool about this study is that it was an off-label use of ketamine, and I believe oral ketamine is available in Europe, and I could be wrong about that, but it's really not readily available in the United States. And so some changes have occurred where it's becoming more available. And this population of patients that's chronic refractory migraines, they're in really, really tough shape. It's actually a desperate situation where all therapies have failed. And so if there really is an outpatient approach that will help mitigate some of their suffering, that's a big story. And it brings up a lot of issues of addiction medicine. Is it safe to do this? So getting some entry-level data about a practice was really exciting to us. And they looked at 242 subjects. There were 160 women in the study, and they had an average age of 44. They reported a median intercontinental range of 30 monthly headaches. And I just thought that was just a absolute massive number. And so I think I would like everyone to kind of check out this study and kind of see how they kind of put this together, because it's a wonderful opportunity to kind of mimic that methodology for someone who has real world pragmatic data. So you really want to kind of check out that study and let me know what you think. Now, the third study, which I think is just incredibly important, isn't really a study. It's more of a guideline statement. And one of the things that we see in terms of our citations in the journal is that guideline statements tend to just do really, really well for the journal. Impact factor of a journal is important. It's not the only thing that matters. We're mission driven, so we'll support publications that will not necessarily contribute to the impact factor, like education articles and some editorials. But there are times where everything aligns perfectly, where we get an article that is super clinically relevant. It has the teeth of a society to really back the recommendations, and then we get all the citations. And this is the case with the ESRA Pain Medicine Consensus Guidelines on the management of perioperative patients on cannabis and cannabinoids. And this is a huge topic, particularly in the United States, because we have this weird world where the use of these drugs tends to be illegal on a federal level, but state by state differences exist, and research is somewhat limited because of that fact. And the other reality is that patients are coming in on these drugs for elective surgery, for emergency surgery, and there are a lot of health implications of using cannabinoids in this setting. And it's kind of the Wild West right now, what things were happening from a policy standpoint, let's say at an ambulatory surgery center. And this guideline provides a really nice educational overview of some of the physiology and pharmacology of the drugs, and also some of the specific clinical concerns that stem from the use of this drug, especially in the acute setting. And so people are using this to kind of formulate their own hospital guidelines and procedures. And I feel really good that the journal could help support that. And I really want to thank the ESRA Pain Medicine Guideline Committee for really seeing this thing through. So we have a really good product here. So check that out if you haven't seen that. And then of course all the other studies, we have a bunch of RCTs, and we have quality improvement studies, and we've got some really cool case reports. So it's been a good year.
Hello, my name's Nuala Lucas, and I'm an anaesthetist working in the UK. I'm currently president of the Obstetric Anaesthetists Association, and it's my great pleasure to welcome you to the obstetric section of the first World Day of Regional Anaesthesia and Pain Medicine. I'm biased, but I think obstetric anaesthesia is an important part of the regional anaesthesia family, and I'm so grateful to ESRA and its sister regional anaesthesia societies for including it within the programme today. Obstetric anaesthesia isn't just another medical subspecialty. It's a field that deals with critical moments in the lives of mothers and their infants. During childbirth, anaesthesia can make the difference between a smooth delivery and potentially life-threatening situation. And of course, key to all of this is education. Education in obstetric anaesthesia is paramount to ensure the safety of both the mother and the baby. The physiology of pregnancy is intricate and dynamic. Comprehensive education equips us with the understanding needed to navigate the challenges presented by changes in the cardiovascular, respiratory, and hematological systems. This knowledge is the cornerstone of effective obstetric anaesthesia. And of course, our care can impact beyond immediate delivery care. Education in obstetric anaesthesia contributes to maternal well-being postpartum. Managing post-delivery pain and sometimes complications ensures an optimal postpartum recovery. And of course, I'm not just referring to physical recovery, but also psychological well-being. We know that we have a second patient as obstetric anaesthetist, and the impact of obstetric anaesthesia extends beyond the delivery room, influencing neonatal outcomes, affecting the health and development of the newborn. Education in obstetric anaesthesia empowers anaesthesiologists to offer patient-centered care. It allows us to make informed decisions, to communicate effectively, and provide compassionate support during labour and delivery, ultimately contributing to a positive childbirth experience for mothers. In conclusion, education in obstetric anaesthesia is not merely about acquiring technical skills. It's about safeguarding the well-being of both mothers and their newborns during one of the most pivotal times in their lives. By investing in comprehensive education and taking part in initiatives such as today, we contribute to a safer, more comfortable childbirth experience and lay the foundation for a healthy start for every newborn. We're here today not just as clinicians, but as a global community committed to the transformative power of regional anaesthesia and pain medicine. Our shared dedication to these disciplines resonates beyond borders, transcending geographical and cultural difference. It's this shared commitment that forms the foundation of the first World Day of Regional Anaesthesia and Pain Medicine. Thank you for your attention, and let's continue to prioritise education for the benefit of all our patients.
Hello, ladies and gentlemen. On this occasion, we will discuss the anatomy of the shoulder joint, focusing on the anatomic details that an anesthesiologist should be aware of in order to perform regional anesthesia techniques effectively in this area. The glenohumeral joint is a synovial joint that connects the upper limb to the axial skeleton. It is a spheroidal joint formed by the glenoid fossa of the scapula, the glena, and the head of the humerus. The glenohumeral joint, the most significant of the shoulder, is the joint with the greatest range of motion in the human body. However, this high mobility of the shoulder comes at a cost: stability, since the bony surfaces provide little support. This imbalance between great mobility and low stability makes it particularly vulnerable to a large number of injuries. In terms of innervation, to be able to determine the most suitable regional technique at each moment. The cervical plexus is a network of nerves that emerge from the cervical region of the spinal cord, C1 to C4. It is divided into two main parts: the superficial cervical plexus and the deep cervical plexus. The deep cervical plexus is located deep beneath the prevertebral fascia, and it is formed by the anterior branches of the upper 3 or 4 cervical nerves. It gives rise to motor branches that innervate the muscles of the neck. The superficial cervical plexus is primarily formed by the anterior branches of the upper 4 cervical nerves and gives rise to cutaneous nerves that supply sensory innervation to the skin of the neck and the posterior part of the head. The brachial plexus is a complex network of nerves that originates from the spinal nerves of the cervical and thoracic regions, C5 to T1. It is responsible for the innervation of the upper limb, including the shoulder, arm, and hand. The brachial plexus is formed by the merging and branching of these spinal nerves, giving rise to several major nerves that control motor and sensory functions of the upper limb. Various nerves originating from the brachial plexus collaborate harmoniously to orchestrate precise motor functions and sensory perception within the shoulder region. This intricate coordination enables a diverse spectrum of movements while concurrently upholding the stability of the shoulder joint. The supraclavicular nerve plays a role in innervating certain areas of the skin in the upper chest and shoulder region. The supraclavicular nerve has 3 branches: the medial, intermediate, and lateral branches. The medial branch, or medial supraclavicular nerve, supplies sensory innervation to the skin over the upper part of the chest near the sternoclavicular joint. The intermediate branch, or intermediate supraclavicular nerve, provides sensory innervation to the skin over the upper and middle parts of the shoulder. The lateral branch, or lateral supraclavicular nerve, innervates the skin over the lateral part of the shoulder. The brachial plexus provides motor innervation to various muscles in the shoulder region: supraspinatus and infraspinatus, deltoid and teres minor muscles, coracobrachialis, biceps, brachii, and serratus anterior muscles. all of them responsible for providing the enormous mobility and stability to the shoulder. The main nerves involved in the joint innervation of the shoulder are derived from the brachial plexus, and they play crucial roles in providing both sensory and motor innervation to the shoulder joint. These nerves include suprascapular nerve, axillary nerve, upper subscapular nerve, lateral pectoral nerve, and for some authors, musculocutaneous nerve. These nerves work together to ensure the proper functioning and sensation of the shoulder joint. They play a critical role in both the voluntary movements of the shoulder and the perception of sensory stimuli, contributing to the overall stability and mobility of the shoulder joint complex. This distribution of joint innervation does not occur homogeneously. Not all the nerves involved have the same clinical relevance. The suprascapular nerve predominantly innervates the posterior-superior region of the glenohumeral joint, constituting approximately 70% of its total innervation, as suggested by the majority of authors. In contrast, the axillary nerve contributes around 20% of innervation to the lower part of the joint. The residual 10% is divided among the lateral pectoral and subscapular nerves, which collectively provide innervation to the anterior aspect of the joint. According to certain authors, the musculocutaneous nerve, via the long head of the biceps tendon, may additionally play a role in providing innervation to a minor portion of the anterior capsule. The suprascapular nerve emerges as the third collateral branch from the upper trunk. It diverges from the brachial plexus, distancing itself until it assumes a posterior position to traverse through the supraspinous notch. Once it passes through the supraspinous notch, passing beneath the superior transverse ligament of the scapula, a muscular branch for the supraspinatus and the first articular branch detach. It descends along the posterior part of the scapula, passing beneath the scapular spine and crosses another notch, the spinoglenoid notch. Here, a new articular branch separates along with the muscular branch for the infraspinatus muscle. The axillary nerve originates from the posterior cord of the brachial plexus, which is formed by nerve roots C5 and C6. It descends down along the posterior aspect of the shoulder, running over the surface of the subscapularis muscle. As it continues its course, the axillary nerve becomes posterior, wrapping around the surgical neck of the humerus, the neck of the humerus just below the shoulder joint. The nerve then proceeds along the medial side of the humerus. Before becoming entirely posterior, the axillary nerve may give off an anterior articular branch. This branch can be involved in innervating certain parts of the shoulder joint. When the nerve reaches its most posterior segment, it bifurcates, sending off branches to innervate deltoid and teres minor muscles, as well as issuing a posterior articular branch. The lateral pectoral nerve, once detached from the lateral cord, pierces the pectoral fascia to join the medial pectoral nerve and form the ansa pectoralis. Before doing so, it sends articular branches to the anterior surface of the glenohumeral and acromioclavicular joints. The subscapular nerve divides into two branches. The upper subscapular branch specifically innervates the subscapularis muscle. The lower subscapular branch gives off small articular branches to innervate the anterior surface of the shoulder joint. The musculocutaneous nerve, a terminal branch of the lateral cord, provides innervation to the three muscles within the anterior compartment of the arm, the coracobrachialis, biceps, brachii, and brachialis muscles. Although some authors argue against direct innervation of the shoulder joint by the musculocutaneous nerve, its significant contributions to the muscles of the arm play a crucial role in shoulder movement and overall function. Greetings, ladies and gentlemen. Following a thorough exploration of shoulder anatomy and its innervation, we will proceed to a more intricate analysis of the diverse regional anesthesia techniques at our disposal. This examination will be rooted in an understanding of the brachial plexus anatomy, taking into account the specific nuances that may arise during shoulder surgery. Among the spinal nerves originating from the cervical spine, the ones that play a direct role in innervating the shoulder include the supraclavicular nerve from the superficial cervical plexus, C3 and C4, and the upper and middle trunks of the brachial plexus, C5, C6, and C7. The supraclavicular nerve arises from the superficial cervical plexus, originating from the ventral rami of C3 and C4, and emerges from the posterior border of the sternocleidomastoid muscle. It descends caudally in the neck, deep to the platysma beneath the superficial cervical fascia, before dividing into medial, intermediate, and lateral terminal branches. The medial branch supplies the skin over the upper part of the chest. The intermediate branch provides sensory innervation to the skin over the upper and middle parts of the shoulder, and the lateral branch innervates the skin over the lateral part of the shoulder. The supraclavicular nerve was traditionally blocked by the proximal spread of injectate following interscalene plexus blockade to ensure pain-free surgery involving the shoulder. Recent publications featuring ultrasound guidance for interscalene brachial plexus block have concentrated on using lower volumes of local anesthetic while reducing complications, including the spread of injectate to other structures such as the phrenic nerve. Nevertheless, a reduction of the volume of local anesthetic by over 50% seems to diminish the likelihood of concurrent blocking of the branches of the cervical plexus, including the supraclavicular branch. This may lead to discomfort or pain, particularly during surgeries conducted on fully conscious patients. This circumstance implies that during surgery on conscious individuals, it is recommended to administer either a superficial cervical plexus block or selectively block the supraclavicular branch to provide anesthesia to the skin and subcutaneous tissues in the supraclavicular and upper thoracic regions. A small hypoechoic structure can be identified originating from the root of C4 and lying superficial to the deep investing layer of cervical fascia at the level of the C5 and C6 nerve roots. Scanning caudally, this structure passes superficially over the belly of scalenus medius, deep and posterior to the sternocleidomastoid muscle, and is often seen to divide into terminal superficial branches as we slide our transducer distally. Considering that the suprascapular and axillary nerves originate from the upper trunk, C5 and C6 roots, and that the subscapular, lateral pectoral, and musculocutaneous nerves originate in the upper trunk with contributions from the middle trunk, C5, C6, and C7. To comprehensively address all branches involved in shoulder innervation with a single puncture, one should choose a supraclavicular approach to reach both the superior and middle trunks with our local anesthetic. In an anatomical analysis, it is noteworthy that the principal nerves governing the innervation of the shoulder joint emanate from the brachial plexus, exerting pivotal functions in furnishing both sensory and motor innervation to the shoulder joint. The notable nerves encompass suprascapular nerve, axillary nerve, subscapular nerves, lateral pectoral nerve, and musculocutaneous nerve. As previously discussed, for a comprehensive targeting of all branches involved in shoulder innervation through a unified approach, it is advisable to choose a supraclavicular technique, interscalene, supraclavicular, or superior trunk block. This approach is recommended to effectively reach the nerves involved in the shoulder innervation. Blockade of the brachial plexus effectively provides anesthesia to the upper limb from the shoulder to the fingertips. Approaches to blocking the brachial plexus depend on the indication, planned surgery or procedure, patient-specific body habitus, medical comorbidities, and individual anatomical variants. An interscalene brachial plexus block is the most common and used regional anesthetic technique for shoulder surgery. It involves the injection of a local anesthetic agent into the interscalene groove, which is the space between the anterior and middle scalene muscles in the neck. This blocks specifically the superior and middle trunk, from C5 to C7. It induces a sustained block of the suprascapular, axillary, subscapular, lateral pectoral, and musculocutaneous nerves, ensuring the consistent success of the anesthetic technique. It results in anesthesia or analgesia of the upper extremity, making it a valuable technique for pain management during and after shoulder surgery. When high volumes of local anesthetic are used, above 20 milliliters, some authors have considered the possibility of a simultaneous block of the superficial cervical plexus, making it unnecessary to perform it separately. However, since the trend is to use progressively lower volumes for this block, it is advisable to perform it separately. However, several limitations still exist, including the short duration of analgesia, rebound pain, and a high incidence of unilateral diaphragmatic paresis. In the absence of ultrasound guidance and with the use of high volumes, the technique was linked to a 100% occurrence of hemidiaphragmatic paresis. Moreover, paralysis of the phrenic nerve could lead to significant pulmonary complications, particularly in patients with pre-existing obstructive or restrictive lung disease. Even with local anesthetic dose reduction, the incidence of phrenic nerve palsy is approximately 25 to 50%. In the classical approach, the ultrasound probe is placed over the sternocleidomastoid muscle at the level of the cricoid cartilage, the transverse process of C6, between the anterior and the middle scalene muscles until the roots of C5, C6, and C7 are identified as 3 round hypoechoic spheres, traffic light sign. Supraclavicular block has been suggested to provide effective anesthesia and analgesia for shoulder surgery with a low rate of adverse events. The supraclavicular approach to the brachial plexus block results in anesthesia of the upper limb, including often the shoulder, because all trunks and divisions can be anesthetized from this location. The popularity of the supraclavicular approach to block the brachial plexus substantially increased with the introduction of ultrasound technology, as it greatly reduced the incidence of pneumothorax. Before the introduction of ultrasound, the pneumothorax rate was reported between 0.6% and 5%. The principal advantage of utilizing this approach in shoulder surgery is ostensibly attributed to the anticipated low incidence of phrenic nerve blockade. Anatomically, while a diminished phrenic block may appear plausible, empirical studies reveal an incidence ranging from 25 to 51%. Moreover, this technique is not the preferred choice among most anesthesiologists, principally owing to the potential for incomplete blockade of the suprascapular nerve and the consequential motor block it elicits throughout the limb subjected to the procedure. The ability to image the plexus, rib, pleura, and subclavian artery with ultrasound has increased safety due to improved monitoring of anatomy and needle placement. Because the trunks and divisions of the brachial plexus are relatively close as they pass over the first rib, the extension and quality of anesthesia are favorable. The superior trunk block is a variation of the ultrasound-guided interscalene block with similar sensory distribution, non-inferior analgesia, and significantly less phrenic nerve involvement. While the indications for both techniques are similar, the injection site for interscalene block is in much closer proximity to the phrenic nerve, thus making it more likely for the local anesthetic to diffuse toward it, resulting in either partial or complete phrenic nerve palsy. The superior trunk block, in which injections occur more distal and before the suprascapular nerve separates from the trunk, provides non-inferior analgesia compared with interscalene brachial plexus block for up to 24 hours after arthroscopic shoulder surgery and results in significantly less hemidiaphragmatic palsy, 20 to 5%. Performing the block with less than 15 milliliters of local anesthetic is recommended. Studies have demonstrated non-inferior analgesic results with a lower incidence of phrenic nerve involvement. While it is true that some of the distal branches innervating the shoulder receive additional contribution from C7, and this spinal nerve is not involved in the superior trunk block, studies demonstrate equal effectiveness compared to other blocks performed at this level. This procedure targets the C5 and C6 components of the brachial plexus more distally after they unite into the superior trunk, but before the suprascapular nerve branches off. Research indicates that performing a block above the clavicle does not guarantee the absence of phrenic nerve blockade. In high-risk patients for whom phrenic nerve blockade and subsequent diaphragmatic paralysis or paresis could pose a life-threatening concern, the selective block of terminal branches becomes a viable consideration, specifically targeting the suprascapular and axillary nerves. Approaches to these terminal branches are typically executed post-brachial plexus divergence. The suprascapular nerve is precisely addressed as it courses through the supraspinous fossa, situated above the scapula. The axillary nerve is targeted posteriorly at the surgical neck of the humerus, traversing the quadrangular space defined by the teres minor and triceps. Hello, ladies and gentlemen. On this occasion, we will describe how we perform the interscalene block, the gold standard for shoulder surgery, as a sole technique for shoulder arthroscopy. Interscalene brachial plexus block is the most widely used postoperative analgesic technique for shoulder surgeries. It not only provides excellent postoperative analgesia, but also reduces pain scores and opioid consumption. It involves the injection of a local anesthetic agent into the interscalene groove, which is the space between the anterior and middle scalene muscles in the neck. This blocks specifically the superior trunk C5 and C6 and the middle trunk C7. As of now, the interscalene block continues to be the established regional gold standard for shoulder surgery. While studies suggest a 100% rate of phrenic nerve block with elevated volumes, in reality, only a limited number of patients encounter symptoms indicative of phrenic paralysis. Confronted with this undesirable outcome, it is advisable for patients with respiratory issues to contemplate the adoption of an alternative analgesic approach. In an anatomical analysis, it is noteworthy that the principal nerves governing the innervation of the shoulder joint emanate from the brachial plexus, exerting pivotal functions in furnishing both sensory and motor innervation to the shoulder joint. The notable nerves encompass suprascapular nerve, axillary nerve, subscapular nerves, lateral pectoral nerve, and musculocutaneous nerve. Performing any approach above the clavicle, supraclavicular approaches, would result in a simultaneous block of all branches involved in shoulder innervation, specifically with the interscalene approach to the brachial plexus, which we will discuss shortly. An anesthetic and analgesic block of all these branches is achieved. We suggest initiating the scan from the supraclavicular fossa, where we can identify a cluster of grape-like images adhering to the lateral aspect of the pulsating subclavian artery. This image will correspond to the rearrangement of the trunks, superior, middle, and inferior, to form the divisions. Employing a traceback method, carefully slide the transducer in a cephalic direction. At this level, the anterior and middle scalene muscles lie deep to the sternocleidomastoid muscle, with the interscalene groove between the two prominent muscles. The nerve roots of the brachial plexus will be visualized as oval or round hypoechoic structures located in the groove between the anterior and middle scalene muscles, where they are tightly clustered within their facial sheath. Here the C5-7 roots of the brachial plexus appear as three vertically aligned, round hypoechoic structures, sometimes referred to as the traffic light sign. The goal of this nerve block is to place the needle in the tissue space between the anterior and middle scalene muscles and inject local anesthetic until the spread around the brachial plexus is documented by ultrasound. To accurately identify each of the roots that make up the brachial plexus, we will rely on the shadow generated by the transverse processes at each level. The root will correspond to a round to oval structure in between. The C7 transverse process has a single posterior tubercle, which is why C7 is considered the transition vertebra. As we move the cephalad, transverse processes of C6, C5, and C4 have a double tubercle, one anterior and one posterior. Initiating the scan from the supraclavicular fossa and sliding our transducer cephalad, the cervical level is determined by identifying the transverse process of the 7th and 6th cervical vertebrae. The 7th cervical transverse process differs from the above levels because it usually has a rudimentary anterior tubercle and one prominent posterior tubercle. By moving the transducer cranially, the transverse process of the 6th cervical spine comes into the image with the characteristic sharp anterior tubercle, after which the consecutive cervical spinal level can easily be identified. At higher levels than C6, the anterior tubercle becomes shorter and equal to the posterior tubercle with a shallow groove in between. Another way to determine the cervical spinal level is by following the vertebral artery, which runs anteriorly at the C7 level before it enters the foramen of the C6 transverse process in about 90% of cases. However, it enters at C5 or higher in about 10% of cases. The goal is to identify the anterior and middle scalene muscles and the elements of the brachial plexus that are located between them. The needle is then inserted in plane toward the brachial plexus, typically in a lateral to medial direction. The needle should always be aimed in between the roots instead of directly at them in order to minimize the risk of accidental nerve injury. We must be cautious during needle advancement through the middle scalene muscle, as the dorsal scapular and long thoracic nerves have already diverged from the superior trunk and may occasionally be visualized within the muscle's depth. After careful aspiration to rule out intravascular needle placement, 1 to 2 ml of local anesthetic is injected to verify proper needle placement between the superior and medial trunk. When injection of the local anesthetic does not appear to result in a spread around the brachial plexus, additional needle repositioning and injections may be necessary. There is a keen interest in pinpointing the optimal location for administering local anesthetics during an interscalene block, as the chosen injection site significantly influences the quality of the block. Intraplexus injection involves administering the local anesthetic between the C5 and C6 nerve roots within the sheath surrounding the brachial plexus. On the other hand, extraplexus injections, as demonstrated in the video, entail injecting the local anesthetic between the superior C5 and C6 roots and medial trunk C7 root. In addition to the joint innervation provided by the brachial plexus, the supraclavicular nerve, originating from the superficial cervical plexus, collects the innervation of the skin over the upper part of the chest, the upper, middle, and lateral parts of the shoulder. When high volumes are used in interscalene block, simultaneous blockade of the superficial cervical plexus, including its supraclavicular branch, is assumed. However, due to the routine use of ultrasound for these procedures, there has been a drastic reduction in the volumes used, sometimes less than 10 milliliters. Currently, it is recommended to perform the supraclavicular branch or the superficial cervical plexus block independently, especially if the patient is undergoing surgery without general anesthesia. A small hypoechoic structure can be identified originating from the root of C4 and lying superficial to the deep investing layer of cervical fascia at the level of the C4 and C5 nerve roots. Scanning caudally, this structure passes superficially over the belly of scalenus medius, deep to the sternocleidomastoid muscle. We deposit 2 to 3 ml of a local anesthetic around the branches. When preparing for shoulder surgery, the patient's position is a crucial aspect. The specific position can vary based on the type of shoulder surgery being performed. Most arthroscopic shoulder procedures can be reliably performed either in the beach chair or the lateral decubitus position. It's important to note that the choice of position depends on the surgeon's preference, the nature of the shoulder problem, and the surgical approach. In our environment, the most commonly used position is the lateral decubitus position. The main advantage of this position is that with traction on the arm, there is a good visualization of the joint, and there is an adequate working space within the glenohumeral joint. The patient lies on their side with the affected shoulder facing up. The arm is held in traction parallel to its long axis. Utilizing an interscalene block of the brachial plexus allows for surgery with minimal sedation, ensuring optimal comfort for the patient. Maintaining the patient in normal tension is essential, not only to prevent excessive bleeding during the procedure, but also to guarantee sufficient cerebral blood flow.
Shoulder awake surgery is a safe and efficient choice for many shoulder surgeries, especially under arthroscopy. Regional anesthesia needs to aim 3 targets. Firstly, the interscalene brachial plexus block under ultrasound guidance, with a large spread of local anesthetic from C5 to T1 nerve branches. Secondly, the anterior cervical plexus between interscalene muscles and sternocleidomastoid muscle. Thirdly, to achieve the regional anesthesia, a posterior soft point infiltration without ultrasound guidance. These 3 blocks will anesthetize all the surgical site and increase patient comfort. In our establishment, awake shoulder surgery is performed by all surgeons if patient consents. It is not a special technique for happy few. Awake shoulder surgery simplifies the postoperative pathway. The patient is able to walk to the day surgery unit, where he will understand clearly all the advices transmitted by the nurses, the physiotherapist and the surgeon. The patient is authorized to leave the establishment faster than after a general anesthesia. He turns back home with an accompanying person. The autonomy is the leading concept of awake shoulder surgery.
So I honestly thank all the faculties, Dr. Kala from Mumbai, Dr. Anju from Delhi, Dr. Anjolie again from Delhi, Dr. Pratibha from Raipur, Chaitanya from Bangalore. And not to forget that I profusely thank as well Eleni Moka, who's the ESRA president from Greece, for providing this opportunity to conduct a webinar on the first ever World Regional Anesthesia Day at Sancheti Hospital, Pune. Thank you very much.